This morning, the Finance Committee is holding the second of 3 hearings that we'll be holding this week. And this is a particularly important hearing because our country is now a full year into the COVID-19 pandemic. And let me just give a brief kind of process statement with respect to how we're going to do this. We've got 2 votes at 11:30. And we're going to do everything we can to keep this moving. And we have been working with the ranking member, Senator Crapo, on this. And if we don't do that, we'll probably be here till 3. So we're going to do our best to keep this moving. As I indicated, we're a year in and vaccinations are up. Americans are beginning to feel encouraged. And yet so many families, hundreds of thousands spread across the country, are unable to share in the sense of uplift because they are mourning loved ones that they have lost. Over the last year, more than 175,000 long-term care residents and workers, including 130,000 living and working in federally certified nursing homes, have died of this terrible disease. They were at the center of a collision of mismanagement. In too many nursing homes, even before the pandemic, there was chronic understaffing, slipshod plans for infection control, and abuse and neglect of vulnerable patients. When COVID-19 arrived, the Trump administration came up small by withholding data, failing to distribute protective equipment, and issuing guidance that put seniors in harm's way. This was a systemic, nationwide failure, and it will be challenging to fix. Members can start by agreeing on basic facts. First, what's true of the overall population is true in our nursing homes. Black, Latino, and Native Americans are suffering the worst of COVID-19. A recent study authored by Professor Konetska, one of the witnesses joining the committee, found that the loss of life was more than 3 times higher in nursing homes with the highest proportions of Black and Latino residents compared to facilities with mostly white residents. Black Americans and immigrants also make up a disproportionate share of nursing home staff. Often, they get paid low wages. More than 500,000 of them have confirmed cases of COVID-19, and thousands have died. There's also real concern that COVID-19 will continue to circulate among those communities where vaccines aren't readily available or where uptake is lower. These disparities in COVID-19 deaths are the result of generations of inequity in society and healthcare. Undoing it is going to take a lot of work by this committee, and I know colleagues feel very strongly about getting it done. Second, the previous administration actively impeded efforts to address long-running problems in nursing homes. You could fill a library with the watchdog reports calling public attention to these issues. Incidents of abuse and neglect, chronic understaffing, horrendous living conditions, inadequate emergency preparedness. This was an industry-wide failure also when it came to infection control. Instead of addressing these questions, the Trump administration dramatically reduced the penalties for failing to meet basic protective federal standards. They went out of their way to undermine a chance for real accountability. When states rushed to develop COVID policies, some followed Trump administration guidance that encouraged nursing homes to accept patients regardless of whether they tested positive for the virus. When the pandemic was spreading and nursing homes desperately needed PPE, the Trump administration sent out shipments that reportedly included loose, unusable gloves, hospital gowns that resembled trash bags, and defective masks. The Trump administration did not want people to know about what was going on in nursing homes. Our colleague, Senator Casey, and I spent months pressuring and pleading with them to release comprehensive data. The Trump administration stonewalled, they dithered, they delayed before they finally began to relate. As of now, there still is no reliable data on COVID in nursing homes before May 1st of last year because of the Trump administration stonewalling. One final point. The terrible impact of COVID-19 on seniors in long-term care is not a red state or a blue state issue. It is a nationwide tragedy. Specifically, if you look at the 10 states where nursing homes have been hit the hardest, it's 5 Republican-led states and 5 Democratic-led states. So the reality is long-term care residents in all 50 states were incredibly vulnerable to a pandemic like COVID-19 for long-standing reasons, but the Trump administration worked harder to protect their unscrupulous friends in management than to improve the safety of residents. The Biden administration is working to turn things around. It starts with ramping up vaccinations, creating strike teams of highly trained workers who are going to go into nursing homes and identify the safety risks. This hearing isn't the first or the last time the committee is going to be digging into nursing home safety. We're going to continue to work with members, all members of this committee, because looking after the well-being of America's seniors is at the heart of our jurisdiction. I feel personally strongly about this after my 7 years as co-director of the Oregon Gray Panthers, and I look forward to working with colleagues on both sides of the aisle. We'll start with our panelists and an introduction right after Senator Crapo's opening statement.
Thank you, Mr. Chairman. At the national, state, and local levels, the pandemic has challenged our sense of normalcy. It has tested every institution of daily life we know, threatening the physical and economic health of our nation. Americans from all walks of life have experienced a full year of tremendous hardship and tragedy. It is the people living and working in our nation's nursing homes, however, who bore an outsized burden. More than 174,000 people died as COVID-19 ravaged our long-term care facilities. That number represents almost 1/3 of all U.S. deaths that have occurred during the pandemic. Both long-stay nursing homes and short-stay post-acute skilled nursing facilities rely on direct care workers, such as licensed practical nurses, certified nursing assistants, and personal care aides, to provide most hands-on care. These workers are in close physical contact with residents, assisting with bathing, dressing, and eating. Current data shows that long-term care workers are typically female, and a disproportionate share are women of color. Many of these direct care workers live paycheck to paycheck. Over the past year, they have put their lives on the line. We owe them a debt of gratitude. Thank you to the dedicated nursing home workers like Adelina Ramos, one of our witnesses. These workers hear Americans calling them heroes, but they are often underappreciated when on the job. To these frontline workers, please know that the sacrifices you are making every day do not go unnoticed or unappreciated. Today, we will hear from a number of expert witnesses who will provide key insights into nursing home conditions over the past year. This testimony will help us better understand exactly what happened, when it happened, and why it happened. It will give us insight into policies that produced results, as well as areas that need improvement. Hearings are just one oversight tool this committee uses to hold government agencies, the healthcare industry, and individual providers accountable. Another key part of oversight is securing reliable and accurate data. Transparent data reporting brings accountability and helps drive decision-making. Transparent data reporting brings tremendous support to the system. As we look to the future, it is vital that all states report accurate COVID-19 data. That is the only way for economists, researchers, advocacy organizations, and policymakers to tackle the challenges facing the nursing home sector head on. This is not a job for the federal government alone. Multiple federal, state, and local programs and partnerships work to support the healthcare needs of our nation's most vulnerable populations. We must work together in an honest and transparent manner to safeguard our nursing home residents and the workers who care for them. Over the weekend, the New York Times published the results of an investigation into the Centers for Medicare and Medicaid Services nursing home 5-star rating system. The investigation questions the objectivity and accuracy of the CMS star rating system. This rating system, which was first implemented during the Obama administration, is designed to help beneficiaries, their families, and caregivers compare nursing home quality more easily. Care Compare is another online tool available to help seniors, the disabled, and their families find out if a particular nursing home facility meets federal health and safety standards, staffing levels, and quality performance metrics. After several bipartisan hearings held by the Finance Committee during 2019, CMS implemented changes to Nursing Home Care Compare that specifically denote nursing homes that have been cited for incidents of abuse, neglect, or exploitation. That may have been a start, but clearly there is a lot more work that needs to be done. I'm grateful to each of our witnesses for the work they are doing and for taking the time to join us today. Their expertise will help us advance public policies that slow the spread of COVID-19 and lessen its devastating impacts on our nation's elderly and the disabled. And Mr. Chairman, before I conclude, Senator Scott will not be able to make his statement or participate today, but he's one of the leaders in our Senate on trying to deal with and address this issue properly. And he's asked that I request a statement of his be entered into the record. I ask unanimous consent that his statement be entered into the
Without
record.
objections, ordered.
Thank you very much, Mr. Chairman.
Okay, we're now going to go to our panel, and Senator Whitehouse is going to introduce Ms. Ramos, and we're very glad that you could be here and have known of your efforts for quite some time, Ms. Ramos, so we're glad you're here. Senator Whitehouse.
Thank you, Chairman. Rhode Island lost more than 1,000 nursing home residents to COVID. Nationwide, as Senator Crapo pointed out, there have been more than 174,000 nursing home residents and caretakers who have died. Nearly a quarter of Rhode Island's nursing homes reported shortages of nurses and nursing aides during the pandemic. So I am very pleased and grateful that the committee will be hearing from Rhode Islander Adelina Ramos today. She lived this crisis as a certified nursing assistant at the Greenville Nursing Center in Greenville, Rhode Island. She's a proud SEIU member, and I'm grateful to her and to her union. From late April to Memorial Day, Ms. Ramos witnessed 20 residents at her 160-bed facility perish. She watched a colleague die. In one harrowing moment, she and a team of just 3 staffers cared for over 24 critically ill COVID patients. Eventually, she caught the virus herself and feared spreading it to her family, for whom she also provides care at home. At last, Ms. Ramos is fully vaccinated and hopeful for the future. Senator Casey and I work to provide our nursing homes emergency funding for staffing and testing and PPE, and for nursing home strike teams to boost capacity at facilities in need. We finally got much of this support into the American Rescue Plan, but it had been blocked in all the previous COVID bills. It would have served Adelina and her colleagues better if we had done this earlier, but at least we got it done at last. So I'm pleased to welcome Ms. Ramos here to our committee. Thank you, Chairman, and thank you, Ranking Member.
Thank you very much, Senator Whitehouse. And at this point, I'm just going to do brief introductions for our other guests. Denise Botcher is here. She's the State Director of AARP in Louisiana. She worked for AARP since 2010 and previously was with Governor Kathleen Blanco. Then we will have a very important presentation from a long-term care ombudsman, T. Cobb Moten. She is from Tennessee. She's based in Nashville. She worked with the Alzheimer's Association there, establishing rural senior networks, training first responders, managing early stage engagement programs. And then Tamara Konecka, Lewis Block Professor of Public Health in the Department of Public Health Sciences at the University of Chicago. She serves on a number of federal boards. She received her PhD from the University of North Carolina. We're very glad to have her because we have seen her renowned scholarship, and we look forward to your presentation. So let's begin with Ms. Ramos.
Thank you, Chairman, Ranking Member Wyden and Crapo, and the members of the Senate community. My name is Adelina Ramos. I am a CNA at a nursing home in Greenville, Rhode Island. I am a proud immigrant from Cape Verde Islands off the western coast of Africa. At my facility, I work with Alzheimer's patients. To be trusted by families to care for their loved ones is a great honor. But over the past year, my days have been filled with fear and sadness. I don't think in my small community thought that COVID-19 would arrive at our doorstep, but it did, and nursing homes were not prepared. When COVID first hit, we lost over 20 residents in just over a month, and a CNA died too. We confronted management to let them know we didn't have enough PPE or enough training to keep our residents safe and prevent the virus from spreading in our facility. We're extremely short-staffed too. At one point, I was caring for 26 critically ill residents with the only help of one other CNA, a nurse, and a housekeeper. They couldn't eat, drink, or move by themselves. So some of them require oxygen checked every 15 minutes. And because they had Alzheimer's, sometimes they would get scared. I was horrified. We begged management for more staff on each shift, but they said they couldn't find anyone. And so our residents and staff kept getting sick and dying. The day after Mother's Day, I realized I couldn't smell my ginger tea. I thought it was because of my mask, but a few weeks later, I got the news I had COVID. I didn't have other symptoms, so I didn't know I put those around me at risk. I never thought I would have to tell my son to stay away from me, don't touch me, don't hug me, don't get too close. I would never be able to forgive myself if I infected him. So I did what I had to do to keep him safe. Today I'm COVID-free and vaccinated, and I'm holding my family close. And I'm working to educate others about how important it is to get vaccinated. Things are looking up, but physical, emotional trauma this pandemic caused can't be cured with a shot in the arm. When I started working at a nursing home, I understood I would have residents pass away. In their final moments, our job is to make sure they're comfortable, cared for, and surrounded by loved ones. But family members couldn't come in our facility. The funeral homes couldn't come in either because they didn't have enough PPE. So we became the morticians and had to put bodies into body bags. My residents deserved so much better than what we were able to provide them with few staff and resources. As they took their final difficult breath, I hope they knew we tried our best. The average starting wage for Rhode Island nursing home workers is just $12.34. Some of us have to work multiple jobs to meet our basic needs. Because of short staffing, we don't have time to spend with residents when they need us. My worst day during COVID was when one of my residents was dying and wanted me to sit and hold her hand. But I couldn't stay because I had 20 plus other residents too who also needed me. I feel a calling to do this job and care for others, but passion can't pay bills. I am fortunate that I am a member of my union at CIU 1199 New England. We negotiated higher wage and pandemic pay. We were able to advocate for ourselves and residents, but not every nursing home worker has a union. This issue existed before COVID. COVID-19 just exposed the most tragic and daily parts of nursing home work. It is why I keep fighting for $15 minimum wage and a union for all workers. This pandemic has shown us what happens when we're not prepared to meet the demands for care. We must build back better so that when time comes, when your loved ones need care, and that time will come for all of us, someone like me will be there to answer your call.
Ms. Ramos, thank you. And we wanted you to speak first because we felt that you could really give us a sense of what this was like on the floor where patients live and the challenge. And we knew you were going to give us an important presentation. And thank you, thank you, thank you, because you're speaking for so many this morning. Our next speaker will be Denise Botcher. And let's see, there is Ms. Botcher. Please proceed.
Good morning, Chairman Wyden, Ranking Member Crapo, and members of the committee. My name is Denise Botcher, and I'm State Director for AARP Louisiana. On behalf of our 38 million members, including over 425,000 in Louisiana, and all older Americans nationwide, AARP appreciates the opportunity to provide testimony at today's hearing. The situation in our nation's nursing homes and other long-term care facilities has been alarming since the first COVID outbreak in Washington state. AARP has heard from thousands of people who lost loved ones, and that's why across the nation, AARP has advocated for the health, safety, and well-being of residents and staff. As it's been mentioned, over 175,000 long-term care facility residents and staff have died, and that includes almost 3,000 in Louisiana. This represents about 35% of deaths nationwide. While there may be a sense of relief with vaccines rolling out and infection rates declining, much more is needed to protect nursing home residents. The consequence of not acting is that someone's mother or father dies. One resounding message I've received from families across Louisiana is this: if 175,000 deaths doesn't inspire bold action, then nothing will. AARP has urged action on a 5-point plan to protect the health and safety of residents. First, ensure facilities have adequate personal protective equipment for everyone at the facility and ensure its consistent and proper use, as well as prioritizing testing. Yesterday, I had the opportunity to visit with Mark Ferguson in Lake Charles, Louisiana. His 86-year-old dad and 63-year-old brother lived in the same nursing home, and every week he visited with his dad and brother through a window. And each time he observed staff not wearing masks or gloves. He told me he felt helpless in this moment because it was a matter of life and death. The only thing he could do was call and report it to the administrator. The following week, he'd again visit, and the staff weren't properly wearing PPE. He eventually lost his dad to COVID, and he still fights this battle today. I asked him what keeps him up at night, and he told me the health and safety of his brother Scott. It's unacceptable for facilities to have PPE shortages a year into the pandemic. AARP's second point, continue to improve transparency. We believe care facilities should report publicly cases and deaths daily rather than weekly. That reporting should include demographic data such as race and ethnicity. Information about the number and percentage of residents and staff who have been vaccinated should be available by facility and state. We urge the federal government to work with states and long-term care facilities to ensure they can access and administer vaccines to new residents and staff as needed. Finally, billions of taxpayer dollars from the Provider Relief Fund has gone to facilities to fight COVID. AARP strongly urges that the administration and Congress ensure that these funds are directly used for the health, safety, and care of residents and staff. AARP's third point is to ensure safe access to in-person visitation following federal and state guidelines and require continued access to facilitated virtual visitation for all residents. Our fourth point is to ensure quality care for residents through adequate staffing and oversight. We're deeply concerned about staffing shortages at facilities and were even before the pandemic. According to AARP's nursing home dashboard, over 25% of nursing homes across the nation have reported a staffing shortage since June of 2020. Residents' health and safety are at continued risk without adequate staffing. Finally, oversight and enforcement are a shared responsibility between federal and state agencies. Oversight from CMS, and state survey agencies, including regular annual surveys, is vital now more than ever. AARP's final point is to reject immunity and hold long-term care facilities accountable when they fail to provide adequate care to residents. You know, when I speak to folks young and old about how they want to live their lives, an overwhelming majority tell me they want to live at home for as long as possible with the support of family and friends. Helping people to remain in their homes and communities would help alleviate some of the challenges we are facing in our nation's nursing homes. This includes supporting family caregivers who make it possible. Families across the country are looking to Congress and the administration for swift action to protect the health and safety of their loved ones living in long-term care facilities now and well into the future. We cannot wait any longer. Thank you.
Thank you. Let's go next to Ms. Moten, the Ombudsman. Ms. Moten, welcome.
Thank you. Good morning. Thank you, Chairman Wyden, Ranking Member Crapo, and distinguished members of the committee. I'm Tika Moten, State Long-Term Care Ombudsman for Tennessee. I'm honored to discuss my experiences, challenges, and lessons learned while serving residents during COVID. I want to first thank you for CARES funding and American Recovery Act funding. It has greatly assisted in the provision of programs and activities, as well as the procurement of equipment and PPE in this time. I sit before you as a certified dementia practitioner, trainer, and coach, as well as a former volunteer ombudsman, having spent the entirety of my career in public service, specifically aging programs and policies. I began as state ombudsman in Tennessee, January 17th, 2020. I had less than 60 days to learn my role, staff, and major stakeholders prior to the lockdown. Coincidentally enough, there was also a tornado that affected the Nashville area and the Upper Cumberland region, and this has affected a number of long-term care homes. Swedish for the term representative of the people, the Ombudsman program is an essential component to the oversight of long-term care facilities. We operate as a community-based, at-the-bedside advocacy program for the rights of residents. We handle complaint investigations as laid out by the CMS State Operations Manual. The major components of the Ombudsman program, fortified by the Older Americans Act, include a mandated quarterly visits to our nursing homes by staff ombudsmen and regular visits to communities by trained and designated volunteer ombudsmen, who at the average age of 70 are very much a vital and integral part of our program. COVID, alongside ensuing policies, disrupted the Ombudsman's program immediate access to residents. The inability to have face-to-face meetings made it difficult to verify complaints, assure confidentiality, and readily gain consent for our residents and the medical surrogates or POAs. In addition, it made it difficult for us to advocate on behalf of residents being discharged against their wishes, oftentimes leaving them in behavioral health or medical centers with the risk of losing their Medicaid. Particularly affected by these major barriers were people living with dementia, those who are aphasic or unable to speak, those who are deaf, hard of hearing, or have assistive technology needs, those without the manual dexterity to pick up the phone, and those with that ability but without the funds to purchase their own. Residents, in fact, were not silent. Lack of staffing and an inability to be with their families silenced them. But staffing issues were nothing new in the most regulated industry in this country. Nursing homes were already dealing with the workforce shortage, and COVID exacerbated that issue further. Staff members got sick, as you've already heard. Many had to quarantine, and some faced a lack of childcare options. What resulted was an overall decline in the quality of care that our residents received. Throughout the country, ombudsmen received complaints of dehydration, unanswered call lights, a lack of basic care and assistance, cleaning, bathing, feeding. What most identifiable, probably repositioning, which left residents in the bed, resulting in an exponential increase in bed sores. Unchanged catheters and pressure sores resulted in sepsis and sometimes death for our residents. There are issues of dignity and hygiene stemming from residents having to sit in their own feces and urine for hours on end. There were delayed discharges to EDs for serious conditions, access and transport issues to dialysis and other appointments, and an uptake in facility-initiated hospice. Residents dealing with COVID, its reoccurrence, testing, and room changes had to deal with resident isolation. This led to emotional distress and physical decline. I can remember vividly calls from skilled rehab residents who would recount their experience in facilities. For me, the toughest part was knowing that if we received calls to our hotline on the weekend and the evenings, it was more likely than not a resident who knew that there were going to be less staff in the building. Worried family members also shared their concern for unkempt residents as they looked at on and discontinued at disheveled hair, unbrushed teeth, and filthy fingernails. This added to our task of helping family caregivers adapt to a different type of caregiver role, especially for those moving into facilities in the midst of COVID. But for those who would take their final breaths in nursing homes, the term compassionate care altogether presented another set of challenges for us in dealing with the discretion of facilities. Ombudsman worked tirelessly throughout the last year. Ideally, the worst has subsided, yet the fact remains residents of long-term care make up less than 1% of the US population. But as of March 4th, 2021, account for 34% of all deaths in America. As we move forward, it's my hope that we can lean on a few actionable items. For facilities, a comprehensive plan for recruiting and retaining staff. For the Ombudsman program, consideration as an essential part of a system that responds to and supports the safety and welfare of residents, regardless of any status a state may bestow upon them. And last but not least, for the residents remaining in our facilities, the loving embrace of family, friends, pets, and a return to some version of normalcy.
Thank you very much. Our next two witnesses will be John Dicken, Director of Healthcare at the Governmental Accountability Office, where he's worked since 1991. He oversees a portfolio of audits on healthcare questions, and he's been before us before, and we appreciate it. And then we'll close with Dr. David Gifford, an MD and a Master of Public Health, Chief Medical Officer of the American Healthcare Association and geriatrician. So let us proceed now to Dr. Konecka.
Chairman Wyden, Ranking Member Crapo, and distinguished members of the committee, thank you for holding this hearing. My name is Tamara Konecka. I'm a professor of health economics at the University of Chicago, and I've been conducting research on long-term and post-acute care for more than 25 years, and have intensely studied COVID-19 in nursing homes during this pandemic. I'll focus my remarks on what we've learned from research, followed by recommendations. First, what do we know about the predictors of nursing home cases and deaths? A large body of evidence shows that the two strongest and most consistent predictors of worse COVID-19 outcomes are larger nursing home size and COVID-19 prevalence in the surrounding community. Given two similar nursing homes with an outbreak, being in a virus hotspot is associated with 5 more deaths. Equally important are nursing home attributes that are not linked with COVID-19 outcomes. Multiple rigorous studies have found no meaningful association between COVID-19 outcomes and standard quality metrics. Even prior infection control citations were not associated with COVID-19 outcomes. These results suggest that high quality and good infection control are not enough in this pandemic. The numbers bear this out. At this point, more than 99% of nursing homes in the nation have had at least one COVID-19 case, and more than 80% have had at least one death. This is clearly not a bad apples problem, and no subset of nursing homes has found a magic bullet to keep the virus out. The single most important thing we could have done as a nation to reduce the tragedy in nursing homes over the past year was to use public health measures to control the spread of the virus in the general population. Second, what about disparities? As Chairman Wyden mentioned, our research found striking disparities by race. Nursing homes serving more residents of color experienced more than 3 times as many COVID-19 cases and deaths as those serving primarily white residents. Why? Most of the disparity can be explained by what race is correlated with. Residents of color are more likely to live in larger facilities in neighborhoods where COVID-19 is prevalent. Third, are there any predictors of bad outcomes that are more amenable to change? In the often contentious world of nursing home policy, it's difficult to find things that everyone agrees on, but here's one. On average, nursing homes lack sufficient numbers of staff to provide the quality of care we would all like to receive. In our research, we found that having more staff did not reduce the probability of a COVID-19 outbreak, but nursing homes with the most staff hours experienced fewer deaths and cases once an outbreak occurred. The effects of staffing are still dwarfed by the effect of community spread, but increasing staffing represents a clear intervention that could improve care and save lives during this pandemic and beyond. This evidence base suggests several policy recommendations moving forward. First, policies implemented during the past year that reward or fine facilities based on COVID deaths are not appropriate in a crisis. Instead, I strongly support the allocation of American Rescue Plan funds to provide strike teams to rapidly fill staffing gaps during an outbreak. Second, we must provide greater assistance to large facilities in communities of color. Such facilities do not typically earn performance bonuses, but may be most in need of resources. Third, American Rescue Plan puts substantial funding into improving infection control. Although improvement is certainly necessary, we should recognize that this is a solution to a relatively narrow set of problems, a solution that would not have avoided the tragedy of the past year. Fourth, CMS should immediately release facility-specific data on vaccination dates and rates and demographics, including race and ethnicity, essential for both research and policy. Consumers who are considering nursing home care also have a right to know what % of residents and staff have been vaccinated. Finally, direct care staffing in nursing homes needs to be increased. Addressing this challenge requires resources, which is where the agreement about staffing ends and the harder problems begin. Many argue, and I largely agree, that America's long-term care system is grossly underfunded. At the same time, the growing role of related party transactions and private equity ownership makes it difficult to see where taxpayer money is being spent and what profit margins truly are. Greater transparency about the flow of money is urgently needed. We will never achieve adequate nursing home quality unless we find a way to support the workforce. In addition to low pay and few benefits, the job of direct care nursing staff is difficult, often dangerous, and emotionally and physically taxing. Add the risk of a potentially fatal infectious disease, and it's amazing they show up. Addressing this challenge is the best way to honor the memory of the more than 1,900 nursing home workers and all the residents who have died from COVID thus far. We can't turn back the clock to prevent the tragedy of the past year. We can at least take steps to learn from it. Thank you.
Thank you. Okay. Thank you very much. Our next speaker will be John Dicken.
Well, good morning, Chairman Wyden, Ranking Member Crapo, and members of the committee. Thank you for the opportunity to discuss GAO's findings and recommendations on the federal response to COVID-19 in nursing homes. As characterized in the title of today's hearing, and as you've heard this morning, the last year has indeed been a national tragedy for nursing homes, residents, and their loved ones. Just over a year ago, a Washington state nursing home was battling one of the first major outbreaks of COVID in the United States. Today, the pandemic has reached nearly all nursing homes in the country. More than 130,000 nursing home residents have died from COVID-19, representing nearly 30% of all COVID-19 deaths reported by the CDC as of early February. Even for those nursing home residents not infected, nearly all have faced increased isolation and restrictions on visits from loved ones. The pandemic has also posed tremendous challenges for the homes and their staff. Notably, more than 500,000 nursing home staff themselves have contracted COVID-19. In response to this unprecedented national emergency, HHS has taken a series of actions. These include providing guidance to states and nursing homes, developing targeted inspections to focus on infection control practices, and distributing testing devices and vaccines to homes. GAO continues to evaluate the federal response to the pandemic in nursing homes as part of a series of comprehensive reports to Congress on the government-wide response. My statement today highlights a few key findings and recommendations from these reviews during the pandemic, as well as our longer-term work examining nursing home oversight prior to the pandemic. With the ongoing administration of vaccines to nursing home residents and staff, nursing homes may be beginning to see a reprieve as cases and deaths decline by more than 80% as of February from their peaks in December. Just last week, CMS updated its guidance to expand resident visitation. This issue has posed an ongoing tension between providing residents the ability to have visitors, which can benefit their overall mental and physical health, and minimizing the potential for a COVID-19 outbreak. Other challenges nursing homes have faced in battling COVID-19 include obtaining personal protective equipment and conducting COVID-19 tests. Although these challenges are still notable, they have generally shown signs of improvement. Some new challenges have also emerged, such as reluctance among some staff to receive a COVID-19 vaccine and the need for continued vigilance with the emergence of more highly transmittable virus variants. GAO has made 2 recommendations specific to HHS's response in nursing homes to date. The first recommendation is for HHS to develop a strategy for having more complete data on COVID cases and deaths in nursing homes, which were only voluntarily reported until last May. The second recommendation is to more systematically develop a plan detailing if and how the Centers for Medicare and Medicaid Services will respond to remaining recommendations from a commission appointed by former Administrator Verma and publicly reported last September. To date, CMS has not yet implemented these recommendations. We maintain the importance of these recommendations to better inform the government's continued response. We also made a number of recommendations to improve nursing home oversight as work completed prior to the pandemic that have yet to be implemented. For example, less than 2 years ago, I testified before this committee regarding GAO's report on abuse occurring in nursing homes. That report made 6 recommendations to CMS, including that CMS requires state survey agencies to immediately notify law enforcement of any reasonable suspicion of a crime against a resident. These recommendations are particularly relevant during the COVID-19 pandemic because with reduced visitors, ombudsman, and state surveyor presence, there may be a higher risk of abuse going unreported. In closing, GAO's recommendations could help address some of the challenges nursing homes continue to face and fill important gaps in the federal government's understanding of and transparency around data on COVID-19 in nursing homes. Going forward, the spotlight that COVID-19 has placed on the vulnerability of nursing home residents may be best used to inform future pandemic responses and refocus on long-standing challenges that place nursing home residents' health and safety at risk. This concludes my prepared statement.
Thank you very much, Mr. Dick. And Mr. Gifford.
Chairman Wyden, Ranking Member Crapo, and distinguished members of the Senate, thank you for making long-term care providers a priority as you examine how COVID-19 has impacted the nation and for providing our association the opportunity to share our members' challenges during the pandemic. HCA represents over 14,000 nursing homes and assisted living communities across the country, including not-for-profit, for-profit, and government facilities. As a geriatrician, I can attest that COVID-19 is the greatest tragedy ever to impact our residents and their families. Over 635,000 residents have been infected, and more than 130,000 have died, worse than any other infection or disease we've faced. This virus has also affected healthcare workers, with over a half a million becoming infected and thousands dying. As you know, our residents are at the highest risk for COVID-19 complications. More than half are over the age of 85 and suffer from multiple chronic diseases. Residents depend on our nurses, our aides, support staff, including housekeepers, to help them with their daily activities that require close one-on-one contact, like eating, getting dressed, and bathing. COVID-19 has impacted every aspect of long-term care. For nearly a year, family members were unable to visit. Residents could not leave their rooms. They could not see the smiles of the nurses and aides caring for them, hidden behind their masks. Our dedicated staff did everything they could to keep residents safe, engaged, and happy. Meanwhile, they constantly worried about becoming ill or infecting their family, as Ms. Ramos clearly described. Our hearts go out to the residents, their families, and the healthcare workers who have suffered through the past year, separated from each other, in some cases, forever. Why did such devastation happen in long-term care? The timeline in my written testimony demonstrates how our knowledge of this virus continually evolved, but the public health advice could not keep up, and as a result was typically too late. For example, initial guidance was focused on a symptom-based approach that we now know is ineffective, since half the people spreading the virus don't have symptoms. But guidance on mask wearing for all staff did not come until June, 4 months into the pandemic. Compounding these challenges was the failure to make nursing homes a priority. Despite numerous calls for help, it took months to receive much-needed PPE. In many circumstances, staff had to use their ingenuity to make their own masks, gowns, and face shields. I recall getting a call one weekend asking if rain ponchos worked better as gowns than trash bags. As we now know, COVID-19 outbreaks in nursing homes are principally driven by how many people in the surrounding community have COVID, as Dr. Cnas testified. But testing kits need to detect asymptomatic carriers of the virus were not provided to nursing homes until almost 6 months into the pandemic. As a result, staff in these communities often unwittingly brought COVID-19 into buildings. With these delays, even the best nursing homes with the most rigorous infection control practices could not stop this highly contagious virus. The long-term care community was left behind, forgotten, and even blamed. This further demoralized the staff who are risking their lives and trying their best with inadequate support. It's critical that we determine what we can do to keep this from ever happening again. We must reflect on the challenges within the long-term care profession that this pandemic has exposed and exacerbated. We recognize that providers can and must do better to meet the needs of the elderly. Prior to COVID-19, and only made worse by the pandemic, the long-term care struggled to attract and retain a highly dedicated workforce, particularly registered nurses who are most in need during an infectious disease outbreak. Our ability to find nurses and other caregivers is correlated with the lack of their availability and proper funding. As many academic experts have highlighted, chronic Medicaid underfunding makes it a challenge for providers to compete with hospitals for nurses and make infrastructure changes. What we've learned from this strategy is that it will take considerable investment to make meaningful changes. We stand ready to work with policymakers and others to take bold action. Earlier this week, HCA and Leading Age together announced the Care for Our Seniors Act, a set of proposals focused on clinical improvements, strengthening and supporting our workforce, improving oversight, particularly for chronically poor performing facilities, and modernizing our physical structures. The good news is that nursing home residents and staff were made a priority to receive the remarkably safe and effective COVID-19 vaccines. As a result, cases and deaths have declined dramatically since mid-December. Making us a priority for the vaccine demonstrates the power of putting long-term care and our nation's seniors first during emergencies. On behalf of the staff and the residents in nursing homes around the country, I would like to thank the Senate and the members of this committee for your dedication and leadership during this pandemic. We look forward to working with you on implementing constructive solutions to combat COVID-19 and usher in a strong long-term care system.
Thank you, Mr. Gifford, and all of you have been excellent. I'm going to begin my questioning with you, Ms. Ramos, because I was listening to what you said, and it was clear you too were at the center of this collision of mismanagement. You talked about the understaffing issue. You talked about the problems getting PPE, protective equipment. You mentioned the fact that you all were in the dark with respect to getting information. And I think apropos of information, I heard you say that there was concern among healthcare workers, and you initially, about getting vaccinated. Do you think getting more good information out, particularly in communities of color, about the success of vaccination would really be helpful?
Yes. I had to do my own research. I was scared to get vaccinated. I talked to my union reps about the vaccine, and I got the information. But I think most of my coworkers, they feel the same way. They don't want to be the guinea pigs of the system, because what we went through, it was horrible. We didn't get the help that we needed, and we feel like the companies just want us to be the guinea pigs. But if there's more information in the community, because we all have different backgrounds, we all speak different languages, and we come from everywhere. So if there's more resource in the community that and leaders that they trust, it would be easier for them to get vaccinated. So they should talk to their church members or somebody that speaks their language to, the leader in the community to help them out.
Your point is so logical. It's almost like you're being too logical for Washington, D.C., because you shouldn't have to be a private eye to get this information. So we're going to follow up with you on that, and just, again, so appreciate your leadership. Ms. Konetsky, let me turn to you. I'm very appreciative of the fact you mentioned the strike teams, because I think they're extraordinarily important in bringing expertise to this issue. We had a floor fight during our 24-hour day where we had to defend it, and fortunately we prevailed. I'd like you to amplify on your concern, because I share it, about private equity getting more involved in this field, because my concern is, and I heard Ms. Ramos make another point, that she's concerned all they're interested in is money and the like. This trend towards more private equity looks to me like something that the Finance Committee should be digging into, and I thought maybe you can amplify on your statement.
I agree. I think it would be a good thing if the Finance Committee could look into this. The increasing role of private equity in nursing homes, along with other complex arrangements like the related party transactions, is a problem. There's really interesting recent research showing that nursing homes bought by private equity subsequently have higher revenues, but lower staffing and worse patient outcomes. And when those revenues are coming from public funds, this is not acceptable. And I think regulators have been reluctant to interfere with ownership transactions in the industry, an industry that was mostly for profit, but it may be time to do so, at least in the sense of transparency. So, if we think about assistance and or potentially increasing reimbursement rates so that we at least know where the money is going, even with current reimbursement rates.
We're going to be calling on you again on this issue, because it seems to me this is an area that has not gotten the oversight and the accountability that is needed, and I'm glad that you have lit this concern up in front of the Senate Finance Committee. Question for you, Ms. Moten, and so appreciate your ombudsman role. When I was director of the Gray Panthers, we worked with the ombudsman, and dollar for dollar, y'all make such a big difference. We've been reading about how these rating systems aren't doing particularly good job of rating. What would you do with these, and have as counsel for the Finance Committee some direction at improving them?
Honestly, I'm not exactly certain what I would do to change the rating system. I think that a lot of what we see as ombudsmen are that facilities are on their best behaviors when health is in the building oftentimes. And so I think that some more impromptu approaches to that will probably be the best way to work through those issues.
Well, three cheers for getting us started on that, because when I was on the nursing home board, if they knew you were coming, everything was perfect. And that's a very important suggestion. We'll call on you again. All right, I'm over my time. And our next member, we see our friend, Senator Crapo.
Thank you very much, Mr. Chairman. And I'll start with you, Mr. Dickin. In your testimony, you mentioned a statistic, if I got it right, that the deaths in nursing homes had gone down by 80% by February. Could you give me that correct statistic again? And if that's generally correct, could you tell me, do you have an idea as to what we can attribute that reduction to?
Yes, thank you, Ranking Member Crapo. And you do have it correct that what we've seen from reporting from HHS is that from the peak of cases and deaths in nursing homes in December until reporting early last month, the cases and rates have declined by 80%. And we're pleased that decline has continued even beyond early February. Certainly, we are continuing to evaluate kind of what some of those factors are. There's still need for continued vigilance. That is a sharper rate of decline than we have seen throughout the broader community. There has been declines in cases and rates outside of nursing homes, but it does seem to be sharper. Certainly the prioritization of vaccination of nursing home residents and staff is a key thing to look at, and why it has been an even faster decline in the rates and trends recently for nursing homes.
Well, thank you. It seems to me that something must be being very helpful. Something's working, and we need to identify exactly what that is. And so I'd appreciate your assistance in that. GAO has issued at least 4 reports regarding the federal and state response to COVID-19 in nursing homes. And I don't want to use up all my time on this because I've got a few other questions with others, but you mentioned that SEMA Vermin had issued some recommendations that have not yet been implemented. And I believe that GAO has made a number of recommendations in its reports. Could you pick just a couple, like 1 or 2 of the most important recommendations you think are yet to be implemented and need to be?
Yes, and I'll be brief. That you noted that the former CMS administrator had a commission that made over 27 recommendations on ways, both short-term and long-term, that CMS could help respond to the pandemic. CMS took a number of steps, but we have recommended that they do a more systematic plan on how they could more fully continue to draw from the expertise of the commission that was appointed, and would recommend that that would help improve the federal response. The other one I would highlight is that the data is very important for oversight and for transparency, and that prior to May that was voluntary, and we recommend that CMS identify a strategy to have more complete data for the early months of the pandemic. That's very important, not only for ongoing response, but for understanding lessons from the pandemic over the course of its time.
Well, thank you. And we want to work with you and all of our witnesses. I know our ombudsman, and I won't be able to get to you in my questioning, but there are a lot of recommendations out there from all of you. We need to know what is working and what needs to be done better, and encourage you to give us that information. I'd like to move quickly to Dr. Gifford. Doctor, how did the AHCA respond to certain state directives mandating that long-term care facilities admit active COVID-19 cases?
Thank you, Senator Crapo, for that. I think as we heard from Ms. Ramos and others, there was just chaos in May and April. The nursing homes were terrified of this COVID. Families were terrified, staff were terrified, and hospitals were terrified. We saw in some cities, lines forming in hospitals and creating intensive care units in the parking lot in tents. And so there was sort of a lot of trying to figure out what was going on out there. And as a result, we saw variations in different recommendations that were out there. Nursing homes typically play an important role in emergencies in that they take on patients out of the hospital to free up hospital beds to deal with the emergencies. In this situation, though, freeing up the beds and taking people out of the hospital could potentially lead to further spread. And so that was sort of a worry and concern that we had. But we realized we needed to play a role in the healthcare system, because any decision that was going to be made was going to have dire consequences. If you decided not to move people out of the hospitals, you move people into parking lots. If you move people into nursing homes, you might create spread. And our position was to try to create special units and making sure there was enough PPE and enough sort of staff that were out there. That was really lacking, and I think you've heard from the testimony that was out here so far.
Well, thank you. And I see my time has run out. It runs out quickly. For those of you who I didn't get to, I'll submit some written questions to you, and I would really welcome your responses to these. Thank you very much. Thanks, Mr. Chairman.
Thank you, Senator Crapo. Senator Stabenow.
Well, thank you very much, Mr. Chairman, for doing this very, very important hearing. And I think we all know this last year has been a horrible situation. And we have to say that this started with the lack of seriousness by the former president and the lack of action by the administration. And certainly that has been something that we have seen with the in nursing homes that has played itself out in a very, very serious way. High quality staff are what make a high quality nursing home, though. And a recent report, has been said, found that the average yearly turnover rate for nursing home staff was 128%. So 128% means the average staff completely turned over in a year. And some nursing homes had staff that changed over every few months, which is a very, very serious issue, obviously. Ms. Ramos, first of all, I want to thank you for your incredible work, particularly over the past year. And I'm really in awe of your courage and your resolve, as well as the colleagues that you work with. You said at one point you were caring for 26 critically ill patients. Can you talk a little bit more about the impact of staff turnover on patient care?
Thank you for your question. So on a Mother's Day of last year, we had a critically ill patients with COVID. They were all in bed. So there was me and another aide with 26 residents and a nurse and a housekeeper. We had to, check their temperature, check their oxygen every 15 minutes. I work in an Alzheimer unit, so it was very challenged because our residents kept taking out their masks. So we kept going to their rooms because their oxygen was dropping because they couldn't keep their mask on. So the quality care, it was horrible. We were only 2 CNAs and most of our residents were in bed. We couldn't sit there with them and talk to them while they were dying. We couldn't keep them hydrated when we know that was a part of it, that you got to keep them hydrated because they couldn't hold a glass of water. So we had to pick and choose, which is a thing that we have to do all the time. This didn't start with the COVID. So sometimes we have to pick and choose who are in the critical condition for us to assist first. And that's things that we do every day. And I don't think we should be put in that position that we constantly have to pick and choose what residents to care for, because we love them, we care for them, and the quality care that they deserve, it's not there right now.
Well, and from your perspective, this sounds horrible trying to figure this out when I'm sure you are doing everything you can to care for people. From your perspective and your experience, what's the main reasons that nurses and CNAs leave their jobs at nursing homes?
Well, we don't want to leave our job. I had a thought, during this pandemic, I was like, I can't do this anymore. But then I said to myself, right now is when they need me the most. So why would I leave them when their family members can't come in? So I got up, stick it up, went back to work because they need me. The reason why a lot of CNAs and nurses leave nursing homes, it's because the workload is a lot. We are constantly working short-staffed, and we the CNAs, we make low wages and we have to work multiple nursing homes to pay our bills. So we don't want to leave nursing homes, but we have to do what we have to do for our families.
Of course. And I hear over and over again from our nursing homes that are really doing quality work as well, that not having enough nurses, right, and CNAs is also, along with pay structure, is really an issue. And one of the things right now, staff turnover information isn't made public, which seems to me that that would be important for patients and families. So if I might ask Dr. Konetzka, you're on the technical expert panel that advises CMS. Do you agree this information should be made public?
Yes, I think turnover information is really important. There's a large body of literature tying higher turnover to worse patient outcomes in nursing homes. So I think that information could be useful. I think there are bigger gaps in terms of what we report, such as quality of life and customer satisfaction, but knowing turnover could be helpful to consumers.
Thank you. And then just finally, I know I'm running out of time, but Dr. Kuniska, in your opening statement, you included recent findings that nursing homes with higher proportions of non-white residents experience death counts 3 times higher than those facilities with higher proportions of white residents. So like so many other areas, you know, we've seen long-standing racial disparities put under bright lights under COVID, certainly. But could you, based on your research, what would your recommendations be to address this?
I would divide that into short-term and long-term recommendations. I think in the short term, we need to make sure the assistance gets to those facilities and communities of color because they are the ones experiencing the worst outcomes. So strike teams, for example, we have to make sure they get to those facilities. I'd say also with vaccination, we don't have the data to know this. The data need to be released, but we need to make sure that vaccination is equitable and that people in nursing homes, in communities of color, and people out in the community in those same neighborhoods get vaccinated.
This is an incredibly important topic, and we're going to return to it. We just have to move on because we have so many other senators waiting.
Thank you.
Our next senator is Senator Grassley. No Senator Grassley. Senator Cantwell is next.
Thank you, Mr. Chairman. Thank you for holding this important hearing. State of Washington was one of the first states to record the impacts of the COVID-19 virus. And many people may remember on February 10th, the Life Care Center in Kirkland, Washington reported an outbreak of COVID-19 within the facility that ultimately would claim 46 lives. In the state of Washington, nearly half of the reported deaths have been in long-term care facilities. That is why in the American Rescue Plan, there were included $750 million in support of nursing homes and skilled nursing facilities, including $500 million for strike teams and $200 million for infection control. This is something my colleague, Senator Casey, and his leadership as part of the COVID-19 Nursing Home Protection Act, which I also co-sponsored with him, was very important legislation. This, I believe, is critical. So I would like to ask Dr. Konotska how this utilization of both strike team and staffing issues can help protect nursing home residents during these times of major outbreaks.
Thank you for that question. I think the strike teams are essential. I think it's been a good tool all along for states that have decided to do that. The problem is that nursing homes, even prior to the pandemic, were often understaffed, and the pandemic exacerbated that for all the reasons we've been talking about. Staff were sometimes getting sick or afraid to bring the virus home to their families or needed to stay home with kids who were learning online. And so you really can't implement the best practices that we now know can address a COVID outbreak, such as testing all residents as soon as there's a case in the facility, such as separating residents and assigning dedicated staff to COVID positive versus COVID negative residents so they don't have to go back and forth between the two. All of those things take staff. And in the short run, you know, we can't incentivize facilities into finding more staff and hiring them in the middle of a crisis, in the middle of an outbreak. So the strike teams are really essential to fill those gaps. Time is essential. Once you have an outbreak, you really need to deal with it immediately, and that's what the strike teams enable.
Well, I think my question is, what else can you do in the coordination? I think in this case, the pandemic was new to the United States. We were at the very first impact. The Life Care Center of Kirkland was at the very first initial impact. I think the University of Washington stepped in and tried to help from both in helping and identify and testing. But it's almost at that point you need more leadership beyond just the facility itself. So what else should we be doing to consider the coordination with the strike teams of some almost if not global technically, but theoretically global input to help on these crises?
Yeah, to me, this is about policy leadership as well. I think the strike teams have mostly been facilitated through states. And the strike teams need to come, of course, with some coordination and technical assistance. There needs to be state leadership to identify which nursing homes really need this help and coordination in getting them there and filling the necessary gaps.
Do you think we have those protocols in place now?
I think it's unclear. I think there are still some things that need to be worked on in terms of overall coordination.
I think you're right too. That's why I asked the question. I think we really need to think about this in the sense of protocols that need to be established because this is such a painful experience for everyone. And I think knowing how we would improve upon it in not just the strike teams, but the larger coordinated effort in marrying everything together, I think that would be great. Thank you so much. Thank you, Mr. Chairman.
Oh, and our next witness will be, or a question will be Senator Thune. Senator Thune, are you out there? Senator Menendez. Senator Portman. Senator Cardin. Senator Toomey. Senator Brown. And I see Senator Cassidy.
Super. Am I up?
Yes.
Okay. Let me ask this, because when I speak to providers, I'll probably go first with you, Mr. Gifford. I spoke to folks back home who ran nursing homes. They're having an incredible problem with staffing during the pandemic. And what they told me is that the initial stimulus checks that were as generous as they were, as we know, about 80% of folks were making more money on stimulus checks than they were working, killed his ability to recruit staffing. Now, this does not address the longer term staffing issues, but it does beg the question of whether or not the increase or the decrease in staffing associated with the pandemic could have been associated with government policies, which in effect paid more to folks not to work than to work. Mr. Gifford, any thoughts on that? And then I'll probably come back to you, Dr. Konecka.
Thank you, Senator Cassidy. You know, as we've heard, I think from all of us that workforce is a challenge and it was exacerbated with this. A lot of healthcare workers were homesick and couldn't come in, so that even made it worse. We did put together a training to train many of the unemployed that were out there, and we had over 200,000 people come through training to do temporary aids, which we would love to see get into permanent aid positions and move on to become nurses out there. So there was a lot of demand of people coming in and helping to work. I think a lot of it was more around the licensure and the bureaucratic aspects of getting healthcare workers into this sector was the biggest challenge I think that we faced. And we're really thankful for many of the states and the federal government for some 1135 waivers to make that more effective.
Okay, and Dr. Konecka, it does seem intuitive to me, though, that if somebody can make 20% more on transfer payments as opposed to working, and if you are doing so, by the way, it suggests that you're kind of economically challenged to begin with, that there was an incentive for folks to retire from the workforce in order to do this. You're the economist. What are your thoughts?
Nobody's collected data on that. I think what I've found anecdotally from talking to people who work in nursing homes is that that really wasn't a major reason why nursing homes were understaffed. And I think when you look at people who work in nursing homes, some of whom are on this panel, people generally have different motivations for doing that work. And you really can't be in it for the economics solely if you work in a nursing home for low wages, take care of people, endure sometimes really physically and emotionally taxing work. So I would guess, although we don't have data on it, that a lot of the workforce shortage had to do with pandemic related realities, fears of getting sick, having family at home that you don't want to bring the virus to, or having kids at home, plus competition from other sectors. Hospitals were also competing for these same workers.
So let me
I
ask
don't
you-
think the incentives were a major force.
Gotcha. Let me ask you this. Again, if I speak to folks in the industry, they will say that since many of them, and we notice the racial disparity among those affected, that the racial disparity suggests, we don't know for sure, that the nursing homes most impacted were those which are most likely to have Medicaid as a primary payer. Now, to what extent do low reimbursement rates affect the ability of someone to have that extra resiliency required to handle something like a pandemic? I'll stay with you, Doctor.
Okay. Are you asking about the resiliency of the workers themselves?
No, the nursing home, the ability to have that kind of redundancy of systems, the extra supplies on hand, the kind of, but believe me, I'm a doctor. So I'll walk into an older nursing home and the rooms are smaller, the halls are more narrow. If you walk into something built for assisted living, in which there's a payer mix, in which there's not just Medicaid, but there's also private pay, that you end up having better facilities, frankly, newer, better kept up. To what degree do low Medicaid reimbursement rates impact the ability of a nursing home to be better prepared for an incident such as we've seen?
I think it's a big problem. There's a lot of controversy here. I think that long-term care system in this country is generally underfunded, and a lot of that is because we depend on Medicaid, and the Medicaid rates in nursing homes in many states are really quite low. When we look at the high Medicaid facilities, they tend to have the lowest staffing ratios. They tend to have very little slack. They're always putting out yesterday's fire. And when you're hit with something like a pandemic, they are least likely to be able to deal with it. They are also the
We're over
facility.
time, so I'll ask you a question for the record. That if you did a regression analysis controlling for your payer mix being predominantly Medicaid, how much does that obviate the racial aspect of this? Knowing that there's somewhat of a correlation between race and being on Medicaid as a primary payer.
Right.
We're out of time. And I just want to give a shout out to Denise from Louisiana. Denise, good to see you. Always wonderful to see a friend as a panelist. I yield back.
I thank my colleague. Next is Senator Portman.
Thank you, Mr. Chairman, and thanks for fitting me in. I want to talk a little about home and community-based services and get the reaction from this great panel of witnesses. In Ohio, about 40% of our COVID deaths were in nursing homes, and that's not atypical, unfortunately, around the country. We tend to have a little higher percentage of people in nursing homes in other states, but 40%. This makes it really the focus and really the worst part of our crisis. 7,000 nursing home residents in Ohio lost their lives over the past year. It has improved recently dramatically because of the vaccinations, and I'm excited about that. But in the meantime, it's been a huge problem. Long-term care, of course, is really important to ensuring seniors and people with disabilities can live meaningful lives. And while nursing homes are essential to our country's long-term care system, they're not the only ones that offer this care. For years, I've championed this push toward home and community-based services, or HCBS, where we can offer long-term care in residential settings that are more personalized and allow beneficiaries to live in their own homes near to their family and their friends and their familiar surroundings. This is what we know about HCBS care. It costs less than nursing home care. It produces similar or better outcomes, and people are happier in it. Furthermore, Ohio data has shown that only 0.3% of all beneficiaries with severe disabilities receiving HCBS died of COVID this past year, or about 120 deaths. So it was more successful in avoiding the fatalities with regard to COVID. Because it works, last year we passed two major efforts that the chair, ranking members, and others have supported. I appreciate that. We passed Ensuring Access to ESPs Act, which allows people on Medicaid who use direct support professionals for HCBS care to have them assist with their hospital care, to help improve outcomes and get them back home quicker. That was really important, particularly for the disabilities community, and Medicaid now covers that. We also passed the Empower Care Act, which authorizes the Money Follows the Person program for 3 additional years. I would like to have gone further on that. And again, many colleagues on the other side of the aisle have helped on this, but it helps transition people from nursing homes to HCBS care. My question to the panel is this: when the pandemic was beginning, what could we have done to better utilize HCBS services and potentially prevent some of these deaths? And second, what policy changes should we now consider in order to further promote such services? And open to the panel.
I'll start. I think it's, I thank you for your efforts to expand home and community-based care. I dream of a system where the funding mechanisms are smooth between nursing homes and home and community-based care, and people and policymakers can decide, how to target that care appropriately, and people can get care where they would like. I only caution that it's not a panacea, that we probably will always need nursing homes. And there are some cases in which home and community-based care can lead to worse outcomes. I think we have to be very careful about targeting. But I think that expansion of home and community-based care in a pandemic or beyond is critical.
Thank you. Mr. Dickin, have you looked into this for GAO?
Yes, thank you. And it's certainly a really important question, and certainly agree that's important, especially in a pandemic, but at any time, to make sure that people are getting the appropriate long-term care in the appropriate setting. In this area, there is much less federal information and data on what's occurring in home and community-based settings or assisted living than in nursing homes. I know that today's hearing is focused on some of the limitations and what is known within nursing homes. You were able to indicate some Ohio-specific information, and there is information at the state level, but many of the same vulnerabilities exist for a population that is at risk, that needs direct support. And we've heard similar types of challenges of things like having adequate protective equipment, staffing challenges. So similar types of challenges, maybe less of a congregate setting in some settings. And so, but also much less information at the federal level on what's occurring in settings outside of nursing homes.
So more data is needed, and if we had that data, we would have a better understanding of what the different outcomes are.
Certainly be helpful, yes.
Yeah. Ms. Ramos or Dr. Gifford, any thoughts?
Go ahead, Ms. Ramos.
I think that in the nursing homes, we need oversight, and Congress are the only ones that can have that law passed. Right now, we fight in a state level, but it's not just our state problems that we have these issues in the nursing homes. It's across the country. And our union is fighting really hard for us to pass a bill that everyone in the states and in this country will have a law that will support the staff and the patients for quality care.
Thank you.
Okay.
Thank you, Mr. Chairman. Dr. Gifford, if you have additional thoughts, I'd love to hear them, maybe with a written response. Thank you very much. Thank you, Mr. Chairman.
Senator Cardin was here before Senator Brown. I apologize to my colleagues. We're juggling. Senator Cardin is next, and then Senator Brown.
Thank you, Mr. Chairman. I appreciate that very much, and I appreciate the panel. This is obviously an extremely important subject. We know that nursing home safety has been a critical part of dealing with COVID-19. I appreciate the challenges that we've had with personnel, with safety of the personnel as well. To talk about an issue that was present before COVID-19, and that is enforcement of policy that nursing homes have in place.
Senator Cardin, we're seeming to have some audio issues on your end. Can you hear me? Why don't we go to Senator Brown and
Nice.
then we'll go to Senator Cardin.
Thank you, Mr. Chairman. Just last month, researchers from leading institutions across the country published a working paper on private equity investment in healthcare, specifically nursing homes. They studied Medicare data from 18,000 nursing home facilities over a 12-year period, examining patient outcomes at private equity-owned facilities. The results are disturbing. Let me quickly summarize. The researchers found private equity firms tend to shift money away from patient care, cutting the number of hours that frontline nurses spend providing care to patients. They also, and Ms. Ramos, I'm sure, is familiar with this because of the union that she's part of that represents some of these workers. They also found that patients at private equity-owned facilities are more likely to be given antipsychotic drugs. They found that patients who receive care at private equity-owned facilities are more likely to die. In fact, the researchers found that more than 20,000 Medicare beneficiaries died as a result of private equity ownership of nursing homes during that sample period of 12 years. Finally, they found that taxpayer spending per patient episode increases by 11%. To summarize, the study found when private equity firms acquire nursing homes, they cut staff, they prescribe more dangerous drugs, more patients die, and taxpayers pay more money. In November 2019, Senator Warren and I sent letters to 4 private equity firms that invest in nursing home care and other long-term care services to request information on how these private equity firms manage their facilities. So, Mr. Chairman, I'd like to ask unanimous consent, Chairman Wyden, to enter this paper by Atul Gupta and his colleagues, as well as the letters Senator Warren and I sent out to these private equity firms and their responses, to enter it into today's record.
Without objection, and I would note, Senator Brown, I've been asking some of those same questions, so I'd very much appreciate it. Go ahead.
Thank you. And we also see this private equity issue. I'm the new chair of the Banking, Housing, and Urban Affairs. We see private equity firms starting in Iowa, we believe, but all over the country, private equity firms buying up manufactured housing, so-called trailer parks, and squeezing those generally low-income residents. So we see it throughout our economy. My question, and I have a follow-up question too, Ms. Ramos, 2 questions for you. First, and make your answer as short as you can. Talk about what the difference between adequate staffing and an understaffed shift means for your patients and what it means to you and your colleagues, if you would, Ms. Ramos.
Thank you for your question. So with the more staffing, we can give the residents a better care. For example, if a resident asks me, if 2 residents ask me if they need to go to the bathroom, I have to pick and choose which one of them to take to the bathroom first. So, and then when we have more staff, another aide can help the other one. But when we work short-staffed, if I'm in a bathroom with one of the residents and a patient has fallen, a patient fell in the dining room, the nurse is calling for help, we have to leave the resident that's in the bathroom and to go help the other resident that just had a fall. So those are type of things that we have to do all the time. We have to pick and choose which resident we have to take care of first. And it's a challenge for the nurses and for the CNAs that we deal with it every day.
Thank you for that good, concise answer. Throughout COVID, higher nurse staffing levels have been associated with fewer COVID-19 cases and deaths. We know that. We know I've introduced legislation to require hospitals to maintain safe staffing levels. I hope this committee, and I know Chairman Wyden wants to do this, can consider ways to improve nurse to patient staffing ratios at long-term care facilities. My last question, Ms. Ramos, I noticed your T-shirt, and I know you're a proud member of the Service Employees International Union. Talk to me about how being part of a union has allowed you to better advocate for your patients.
Being part of my union helps me advocate for and be a voice for the workers that don't have a union and the patients that don't have a family members that will speak up for them. And we do that across the country. And also when we are united and we have a power, so with that power, we got hazard pay during the pandemic. And to make like our voices being heard and really inspires change. That's the reason why I am here today, telling you our stories like in a nursing home.
Thank you, Ms. Ramos. Thanks for your conciseness. Mr. Chair, my time's expired. Thanks very much for having this hearing, Chairman White.
Thank you, Senator Brown. Our next, we got Senator Cardin back. Wonderful.
I think I'm with you now. We
perfectly.
changed the connection.
Perfect.
Thank you very much. First, thanks for this hearing. It's very important. Ms. Ramos, I want to thank you and all the frontline workers for what you've done during COVID-19. You truly have stepped up to help our community, and we thank all of our frontline workers during this time. It's been very challenging. We know of the circumstances when personnel become difficult because of getting COVID-19 and protecting our workers and protecting the residents at nursing homes. It's a real challenge. We recognized this before COVID-19, and that's why we looked at the issue of infection prevention in nursing homes. In 2016, the Obama administration issued certain regulations in regards to the requirements for nursing homes. The Trump administration reduced some of those requirements. I guess my question to you is, do we have adequate federal guideline protection to deal with ongoing issues of infectious diseases? Look, COVID-19, we'll get beyond that at some point, but there are going to be other issues that are going to come up that affect the health of the nursing home residents and the personnel that work in nursing homes. Are we doing enough as far as federal guidelines to require nursing homes to have adequate protection to deal with infectious diseases? Whoever wants to answer it, I would welcome your thoughts.
This is John Dickey, Mr. Yeo, and can just note that certainly even making the point that you made, that even before the pandemic, we found that the highest source of deficiencies that were found in nursing homes were for infection control. And so it is essential that there be focus even outside of this pandemic environment on trying to control and prevent infections and to apply appropriate infection control practices. That is a requirement that that nursing homes have the plan to be able to prevent and control infections that even before this pandemic were the primary type of deficiency that was found in nursing homes.
So, yeah, I guess my question to all of us is that obviously a lot of this can be done administratively, but we in Congress might need to take a look at policies that reflect that. One of my interests is how we share best practices. We know that nursing homes have come up with creative ways to protect their residents and to protect their essential workers. Is there an adequate communication system within the nursing home industry itself to implement the best practices that are being used around the nation? And is there a way that the best practices can make their way to us policymakers so that as we look at legislation, we look at what's working and what's not working and try to develop the best policies for our country? Again, I would welcome anyone on the panel who wants to talk about that as to how we can take the best practices that are being used today to keep nursing home residents safe and the personnel safe, and how we can implement that in federal policy.
This is Adelina. From my experience, we need to have oversight in the nursing homes, and Senate is the only one that can do that. We try to working on through states to have a law passed so we could have like safe staffing for better quality care for our residents. Because before the pandemic, like you said, we have these problems, and with the pandemic, it made things worse. So this, it's not just state by state problem, it's like across the whole country problem. Because my story is unique, but if you ask anybody else and any other states, they have similar stories. They've seen similar things or worse what I've been through. So I think Congress has the power to change the law across the country.
And I think the SEIU can play a major part in that. You have people around the country that have seen what works well and what hasn't worked. And I think sharing that information with us would certainly be very helpful as we try to deal with this issue moving forward. We got to look at the lessons learned as a result of COVID-19, recognizing that infectious disease spread within confined nursing homes is going to be an ongoing challenge in regards to the safety of people in this country. Thank you, Mr. Chairman. I thank our witnesses.
Thank you, Senator Cardin. Next will be Senator Langford and then Senator Casey, and I hope we can get both of them in. We've got a vote going on. Senator Langford.
I will hustle, Mr. Chairman. Thank you very much for doing that. I've been a very outspoken advocate for obviously safety in facilities, all of our long-term care facilities, as all of you have been as well. So I appreciate very much what you're doing for this, but I've also been an advocate to say many individuals in my state, in fact, all the individuals that want it in my state that are in long-term care facilities have already been vaccinated, both the staff and the individuals. Some of them have been vaccinated 5-6 weeks already, been through the full regimen and been on the other side of it. There's a difficult balance there of trying to provide safety to those individuals, but also about access to their grandchildren, their families, other individuals, school groups that want to be able to come in and bless them. What they've seen is some normal activity in the past around the facility and trying to strike that balance. CDC's put out some guidance. States, including my own state, has put out some guidance on their own. Sometimes they're not lining up. So my question on this is, based on where we are right now, what would you recommend that we put as guidance out for individuals that are dealing with real depression and real isolation in a very difficult season of life already? What would you recommend we start to do right now for those that have already been vaccinated in those facilities? So I'd open that up. Dr. Gifford, obviously you're going to be the obvious one in this, but I'd open it up to anyone else that wants to be able to respond to that as well.
Well, I think, I'm glad you're raising that point. And I think we've all seen this, families and healthcare givers, that when you take a frail elderly person and restrict them from seeing their family and can't participate in activities and see other residents, and really have trouble interacting with the staff as well, because many of them have dementia and they don't understand what's going on, it will have dire consequences with that. And I think the challenge is, when do you balance the safety of a virus that has a 20% mortality risk with the clearly devastating impacts you've had with that? I think we're transitioning out of that, which is good. I think this raises just a broader question about how do we move to providing the care and activities in infection control when you have to restrict people's movements around in a building.
Other comments from other individuals?
Yes, please. I'd like to add to that. I think in large part, I think on the temporary nurse aides and how people have gone and gotten the certification to be able to work in facilities, but may not have all the credentials. I think from a logistical standpoint, just simply put, we could allow families to take these same types of trainings toward infection control and universal precautions, and allow for the designation of an essential caregiver. So they're able to be in there and able to come in and help supplement the care that staff may not be able to provide. A lot of these people were going to see their families daily and weekly prior to COVID. And so I think that's just one of many solutions that we can look at across the board. And we, and working through that, they still be held to the same requirements of staffing in terms of testing and, ideally vaccination.
Others that want to be able to comment on that?
I'll just add that the essential caregiver programs that were just mentioned, a handful of states at least implemented these even before the CDC opened up guidance about visits. And those may serve as a model, as a good model for how we should be moving as a country. Those are programs in which some family members could go in on a regular basis, and they took all the precautions that staff took, and I think those were generally very successful.
Yeah. So would you recommend something like this? And let's get past COVID. We're all looking forward to that day. We're past it. In whatever way that looks like for us. We'll have still tough flu seasons in the days ahead. And obviously a really difficult flu can have a catastrophic effect inside of a long-term care facility as well. Would you recommend some of these same processes be carried over into a difficult flu season as well for individuals in long-term care?
Perhaps, but I think it's important to remember that reducing physical risk is not the only goal here. We need to find the right balance between quality of life and seeing family and friends and reducing physical risk. I think the goal is probably not zero risk. The goal is to find the right balance.
I'm glad to be able to hear you say that, because there does seem to be a concern about how do we get to zero risk? And zero risk has a lot of emotional damage on a lot of families and a lot of individuals in their isolation. So many individuals that I interact with will say things like, I have been waiting for 10 months and I've thought in my head over and over, once I get the vaccine, this will be different. And they're experiencing right now nothing different for them, and they've had the vaccine. So they're trying to find some hope in the middle of this as well. So thank all of you for the ongoing work that you've done.
Thank you, Senator Langford. Senator Casey and colleagues, Senator Casey has done 3 separate reports on this issue. He has put an enormous amount of effort into it, and we appreciate it. Senator Casey.
Mr. Chairman, thank you very much for having this hearing. I want to thank you and the ranking member. And Mr. Chairman, I want to thank you for the work you've done to hold the prior administration accountable on these issues that relate to nursing homes and long-term care, and to work with me and with others to move this agenda forward, which we still have much work to do in connection with. And I'm just grateful for this opportunity. Senator Whitehouse, earlier in his introduction of Ms. Ramos, was highlighting some of the work that he's done with us as well, and we're grateful for that. I want to start by offering at least, at a minimum, words of commendation to Ms. Ramos and other frontline workers. In your testimony very early on, you talked about, quote, days filled with fear and sadness in the work that you've done, and we want to commend that work. I was especially moved by the reference you made to when you had contracted the virus and weren't able to hug your son as you would want, and so many Americans have felt that same sense of loss. And the moment you talked about sitting with a long-term care resident and wanting to hold her hand, but being pulled away to the work that you had to do because of staffing issues. So we want to thank you and SEIU for standing up for workers like you. We have to do more than offer words of commendation. We got to start voting with you, both parties, both houses, both branches of government, to lift up the caregiving workforce. We are decades late in doing that. And so I don't ask for your comment, just to let you know that we're thinking about you and realize that we have an obligation to you and those with whom you work. My question will be preceded by a little bit of a background. I want to direct my question to Dr. Konecka. We know that as many of us has referenced the now more than 178,000 residents and workers in long-term care who have died from the COVID-19 virus. This is a terrible, profound tragedy within the broader COVID-19 tragedy. We know that in Congress we've got an obligation to learn from the tragedy and to deliver a common sense response. I worked with Senator Toomey, my colleague from Pennsylvania, on work we did in connection with the Special Focus Facility Program. We did some investigative work and made some changes, but now we have legislation that we've just recently reintroduced, the Nursing Home Reform Modernization Act. It does basically 3 things. Number one, it expands the oversight of the Special Focus Facility Program's candidate facilities. That's a specific type of facility. Second, it increases the educational resources for the facilities that are underperforming. And third, it establishes an independent advisory council to inform Health and Human Services on how best to rank nursing home performance and foster quality improvement. So I'm grateful to be working with Senator Toomey, because some of this work can be and must be bipartisan. Dr. Konecka, do you think that there's merit in expanding the size of the Special Focus Facility Program to more facilities and enhancing the oversight of underperforming nursing homes?
Senator Casey, first of all, thank you for your persistent efforts on the issues of nursing homes and in the area of disparities. I'm fully supportive of your efforts to expand the Special Focus Facility Program. We all know that even though there are many nursing homes who provide very good quality of care. There is a bottom tier of nursing homes that are chronically problematic, and that's the tier of nursing homes that the Special Focus Facility Program is aimed at. It's been a tiny program over the years, and I think you're absolutely right in wanting to expand that program and doing what we can to try to bring up that bottom tier.
Thanks very much, Doctor. And I know that we have about 30 seconds left. I'll just ask quickly, Ms. Botcher, with regard to transparency, and I'll just make it quick without a prelude to say that what do you think we've got to do to give families what they need to make informed decisions about nursing homes?
Well, of course, knowledge is power. And so having transparent data available for families, making it easy to read, being consumer friendly, that will go a long way to helping families understand what's going on with their loved ones.
We look forward to working with you and the rest of the panel. Thanks very much, Mr. Chairman.
Thank you for the good work, Senator Casey. Senator Grassley.
Thank you, Mr. Chairman. Since we're talking about nursing homes, I think I ought to start by saying thank you to every American who has supported our seniors during this pandemic, because our nursing homes house the most vulnerable that we have in our society. And this has been a very challenging year for these seniors, but it's also been a very challenging year for our healthcare workers. Before I get to my first question for Mr. Dicken and Ms. Moulton, let me lead in with this. Last year, the Department of Justice launched an investigation into 4 states' COVID-19 response in nursing homes. These states were Michigan, New Jersey, New York, and Pennsylvania. They pressured nursing homes to admit residents who may have been infected with COVID-19. The CDC only recommended that hospitals discharge patients with COVID-19 diagnosis only to nursing homes that are capable of implementing all recommended infection control procedures. State officials who pressured nursing homes to admit untested or contagious COVID patients from hospitals likely increase the case rate and fatality risk for these residents. Meanwhile, state officials in other parts of the country, Florida is just one example, followed CDC guidance, often with better results. So to Mr. Dicken and Ms. Moulton, how important is it for the Department of Justice to continue investigating these 4 states' violation of civil rights of the nursing home residents and the failed duty to care?
Yeah, thank you, Senator Grassley, and appreciate your long-term leadership on these issues. Certainly, what we are aware that there are both federal and state level investigations ongoing. GAO continues to examine kind of what the experience has been across all states, as this has affected all states. And just 2 key points on that. One is that is one reason why GAO has recommended that there needs to be more complete information that was only voluntarily reported at the federal level on cases and deaths in nursing homes prior to May, so that we can learn some of the lessons that occurred during very uncertain and challenging times early in the pandemic. And secondly, that we have talked to, our ongoing work is looking at the experience of a range of states across the country and hearing common concerns about how best to protect protective equipment, dealing with protecting hospitals and nursing homes. These were challenges that have been faced throughout the country.
I want to echo the sentiments of Mr. Dicken. I think that it's important that we continue to investigate these 4 states in particular, and states across the country, as we're able to take those stumbling blocks and make them stepping stones. You know, the reality is that we could have done a better job in a lot of these places. And while oftentimes our care communities mirrored what was going on in other communities, our hospitals were able to handle infection control. And so I think it's we need to look into this so that we're able to figure out what system breakdowns we had in those different states and better understand it so we don't repeat those same mistakes.
Yeah, both Republicans and Democrat senators have warned President Biden that he shouldn't terminate 56 U.S. attorneys, particularly those that have ongoing sensitive investigations. One is Tony Bacon, U.S. Attorney, Northern District, New York. Ms. Bacon previously served as Justice Department's National Elder Justice Coordinator and who currently has jurisdiction over federal public corruption crimes in the state. The state of New York undercounted nursing home deaths by as much as 50%, and state officials intentionally withheld data for months. Ms. Bacon is the obvious choice to continue a fair and unbiased investigation into possible violations of civil liberties of the elderly and public corruption. So to the same two people, Ms. Dickon and or Mr. Dickon and Ms. Moulton, do you believe U.S. Department of Justice must have a fair, unbiased, and experienced U.S. attorney in the Northern District of New York, such as Ms. Bacon? And when you get done answering, I'll have to say my time's up, but let's hear the answers.
Yeah, thank you, Senator Grassley. And I cannot speak to the specific situation there, but certainly know that there are importance of having fair and complete investigations at federal and state levels. But I have not looked at that specific situation.
Okay. Ms. Moulton.
Again, I echo Mr. Dickens' his position on that. I think that an unbiased party is definitely going to be needed to make the proper recommendations and to do a full investigation. But I can't speak to the person you're asking about.
Okay. Thank you, Mr. Chairman.
Thank you, Senator Grassley. Just one fact quickly before we go to Senator Menendez. When you look at the top 10 states with the highest number of COVID deaths per occupied bed, they are evenly split between states led by Democratic and Republican governors, which supports the proposition this is not a blue state, red state issue. It is a huge national tragedy for the country. Senator Menendez.
Thank you, Mr. Chairman. Mr. Dickon, last June, I led my House and Senate colleagues in a letter to then Secretary Azar and then Administrator Verma pleading for more resources, guidance, and support for nursing homes. At the time, New Jersey had already been on the front lines of the pandemic for over 2 months. 2 months when we were fighting in the dark against an invisible enemy. 2 months where New Jerseyans suffered immeasurable losses and pain. In that letter, I called for a comprehensive national testing plan. We didn't get it. I asked for a strategy to ensure our nursing homes had sufficient PPE. I asked for a plan on staffing shortages and for how to care for COVID-19 positive residents. And I called for greater resources to improve reporting and communication. We didn't get all of those things. And when we did get something, it came slowly and for many too late. So that we can learn from the past, can you talk to us about the harm inflicted by the failure to put in place a national testing plan last spring?
Yes, thank you. And you're right, that is part of GAO's broader work examining the federal response to the pandemic. GAO has also recommended that there be a national testing strategy, and that has not yet been implemented. That's key for several reasons. The national testing strategy would help better target information on what resources and expertise can be used to try to control or prevent outbreaks. It also could assure more consistency so that there's working at state, federal, and private entities working on common goals, and that there be common information that could have more transparency.
Thank you. Dr. Gifford, I recently introduced the PREPARE Act and sent a letter with Congressman Pascrell to the administration requesting that infection control practices be improved in nursing homes to combat the future spread of COVID and other viruses. Your plan also calls for a new focus on infection control by adding additional requirements to the infection preventionist position that is required in all facilities. Could you elaborate on your plan and how these changes would help provide a healthier environment for the residents you serve?
Thank you, Senator Mendez, for all of your efforts on both PPE and infection control. We definitely have supported the infection preventionist program and requirements since the beginning. I think what we've learned is that you need to tailor that infection preventionist to the needs of the facility. A large facility with 400 beds needs more than one person. A 20-bed facility in a rural community does not need the same amount. You also have a facility that takes care of highly acute illness and very sick individuals may need more infection preventionists than those that have less acuity in there. And so we would strongly support it being evidence-based. You also don't necessarily want to say it has to be one person, because if that person gets sick or is out on vacation or not working those days, you want to have good coverage of infection preventionists throughout. So this should be able to be covered by multiple people. So we are asking for an evidence-based approach to addressing this infection preventionist in the nursing homes.
And one final question. Last week, the AHCA sent a letter to the administration asking for next steps for vaccinations at nursing homes. Now, last week, we learned that in New Jersey, only about half of our nursing home staff are vaccinated. Since the pharmacy partnership with retail pharmacies and nursing homes is drawing to a close, it seems to me we need to be sure we can still get people vaccinated in these facilities. What are some of the more creative ways the federal government can partner with our nursing home partners to reach the stated goal of 75% of staff vaccinated by June 30th?
Well, I think the initial plan they had, working with retail pharmacies and getting vaccine out there, was a highly successful program. I think the challenge now is getting vaccine out. There just isn't enough vaccine still coming out and being allocated into the program. And so no matter how innovative a program you have, there is no vaccine in the federal or being allocated out other than a handful of states. We need to not let the gains that we have seen with vaccinations slip. It's also clear, I think, as you heard from Ms. Ramos, that you need to have multiple people sitting down and listening and talking to staff and residents about what their concerns are with the vaccine, so that they can understand what's going on out there. And CDC is sort of working in that area, and we support that effort.
Thank you, Chairman.
Thank my colleague. We're going to keep this going. Senator Crapo has been kind enough to say he will run the hearing while I run and vote. And I think I saw Senator Hassan. Perhaps she'll be back soon. Senator Crapo, if you'll run it, I will be back very quickly.
I will do so. Thank you, Senator Wyden. Do we have any senators who are here at this time? Senator Thune? Senator Barrasso? Senator Warren? Senator Hassan? Well, if no senator shows up, I'll go back into some of my questions. Hold on a minute while I grab my stack of papers here. All right, thank you. I'm going to go next to you, Ms. Botcher. You put in your testimony, you outlined a 5-point plan or proposal that you are focusing on. I was interested in all of those points. Your third point was basically to focus, if I understood it correctly, on safe access to in-person and virtual meetings between nursing home residents and their families. Could you expand on that a little bit? Are you saying that we need to increase in-person, or just make sure that we focus both on in-person and virtual?
So both, in fact, and thank you for the question, Senator Crapo. AARP has advocated when it's safe to do so, to allow for in-person visitation. And of course, CMS updated those guidelines. But in-person visitation, we can't lose sight of the fact that we still have to talk about infection control and follow those procedures. There still has to be adequate staffing to be able to provide and support in-person visitation. and all the other guidelines that CMS has put forward. And so all of that, it's a delicate balance, as we've talked about. In-person visitation would certainly help those who have had some mental decline without that social connectedness. And it would help with the mental health of the person. But we also have to do everything we can to provide for the safety of that person with regard to COVID. And so far as virtual visitation, we believe that Congress could do more to require that facilities facilitate virtual visitation when they cannot support in-person visitation. And of course, we saw that throughout the pandemic with the use of cell phones, with the use of iPads, but this was not done consistently throughout nursing homes across the nation.
Right, thank you. And I was just about ready to go to you, Ms. Konetka, but I see that we may have Senator Thune with us, do we? And if not, I do see Senator Daines. Senator Daines, you may proceed.
Right. Thank you, Senator. Well, I'm glad to be part of this hearing today. It's something that's touched Montanans deeply. Over the past year, our nation and my own state of Montana has experienced loss in so many ways. Our seniors have borne the brunt of this pandemic. In fact, so much so that states like New York have tried to cover up the true toll of this pandemic on nursing homes. The reality is that more than 1/3 of all U.S. COVID-19 deaths are linked to long-term care facilities. We must do more to support our nursing homes, the residents, many of whom have suffered with increased depression, anxiety, and worsening dementia due to COVID restrictions and the isolation. Throughout the pandemic, residents were deprived visits from sons, daughters, new grandbabies, through staring through windows, listening to recordings from loved ones to try to keep these memories alive. And we know that extreme social isolation can have very serious health consequences and can even be deadly. With nearly 2/3 of seniors having received their first shot and millions of Americans being vaccinated every day, we're finally turning a corner. There's hope. Today, nursing home residents across the country can visit safely with their loved ones, and even we've seen examples hugging their family members for the first time in a year. We're making great strides in getting shots in arms across the country, currently at a pace of over 2 million per day. But there are folks who are reluctant to get the vaccine. A February study by the CDC estimated low rates of vaccine uptake among nursing home staff at 38% compared to nursing home residents at 78%. We need at least 75% of the population to be vaccinated for us to achieve herd immunity and get back to normal. I decided to take part of the Pfizer vaccine trial last year. It was offered in my hometown of Bozeman, Montana, because I want to do my part in helping to make Montanans feel confident about the vaccine. My question first is to Mr. Dicken. Can you describe how well vaccine distribution in nursing homes is going? And provide any analyses on the CDC's study on vaccine uptake?
Yes, thank you, Senator Daines. And you're right that as nursing homes have been prioritized for vaccine distribution, more than 99% of homes that participate in the federal partnership have had at least one on-site clinic that could help administer vaccines to offer vaccines to residents or staff. That's more than 4.25 million vaccines have been distributed to residents and staff in nursing homes as of early February, and that number continues to grow. The CDC numbers you cited are correct that has had a larger share of residents who have taken the opportunity to get the vaccinations, and that during those first clinics that occurred under the partnership, a smaller share of staff had agreed to take the vaccinations. There was hope that over time, as there continued to be more opportunities in clinics, that would increase. Just comment that my fellow panelist, Ms. Ramos, her experience, and as more staff see other colleagues who have been vaccinated and the declines in cases, can only hope that that would increase their comfort with receiving vaccination.
Thank you. Got a question for Ms. Boettcher. Last year, I teamed up with Senator Grassley on a bill that would allow for the creation of strike teams in states to help facilities that were being overwhelmed by COVID-19. This bill also supported tele-visitation programs so that nursing home residents would not be as isolated from family amid the stresses of the pandemic. Ms. Betcher, can you speak to the benefits of virtual visits in lieu of in-person visits, and what barriers prevent residents from accessing televisit technology?
Certainly. Thank you so much for the question. ARP has long been supportive of virtual visits. And we have, when the pandemic unfolded and nursing homes were closed, families were shut off from their loved ones. And a lot of them did not already have that set up with their loved one. And so it was incumbent upon nursing homes to facilitate that to the best extent where they could. I think the shortcomings were the infection rates as they rose in facilities with residents and staff. Then you didn't have enough staff to facilitate those virtual visits. You had some nursing homes who were concerned about passing around the technological devices to be able to facilitate that. So there just wasn't a lot of support to be able to do that. So families were then troubled and became desperate. We heard from several families who were so desperate they would go to every single window around the nursing home and just start knocking until they found someone that they could talk to wheel their loved one to the window. And they would call us just in frustration. Some nursing facilities don't have strong broadband connection or lack internet access. That is also a problem that needs to be addressed. And so to the extent to which we can require nursing homes to provide virtual visitation in lieu of in-person visitation when that cannot happen, that should be done.
Thank you. I see I'm out of time. Thank you, Senator.
Thank you, Senator. Senator Warner.
Was that Senator Warren or Senator Warner?
Warner.
Oh,
sorry.
Hey, Elizabeth,
Sorry.
wait your turn.
Sorry, Mark.
Okay. Thank you, Senator Crapo. I want to, got a couple of questions here. One, I want to start on the question of nursing home staffing. This is an issue I've been working on with Senator Tim Scott. We've got to make sure, and we've obviously COVID has shown, the ability of these facilities to recruit and retain quality staff is a challenge. It's oftentimes low pay. Part of that's due to the reimbursement rates. I mean, the margins are quite thin for these facilities. And obviously in post-COVID, I think this problem is only going to be exacerbated. I want to start, Ms. Ramos, as a nursing home worker, could you talk a little bit about this issue and any advice you might have on how we can better recruit and retain nursing home workers? And Dr. Gifford, from the association standpoint, can you speak to this issue as well?
Hi, thank you for your question. So like I said before, the quality care and the short staffing has been before the pandemic. So the pandemic made things worse. For us healthcare workers in the nursing home, it's a big challenge. Most of the time we have 13 to 12 residents that are total care. So when you have that amount of residents per CNA, a lot of them stay in bed for a long period of time. And if when the family members were coming in to visit, they were getting very upset because they would come at 10:30 a.m. and their loved ones in bed. So they would have complained. But as the pandemic hit, we still working short and things got worse. We're lucky that we have a union that back us up, and then we have complaint for the ones that can't speak for themselves, like our patients on the Alzheimer unit. Our union support us to speak up for them. And so with the pandemic, things like got worse, and it's worse in the nursing home. We're still working short staffed all the time, and our residents not getting the quality care they deserve.
Dr. Gifford, do you have a?
Yeah, I think as you heard from the panel, all the panelists today, that workforce needs to be improved and we need better ways to recruit and retain. I think you've heard from us all today that, as you recognize, that some of this is due to the underlying funding. The other challenge is how do we recruit and retain beyond just through the salaries? I think loan forgiveness programs is something we've been championing and we really need help with. That would go right to the workers. Tax credits for people who work in this sector. Subsidies to schools and technical schools, but to have their graduates working in long-term care. What we've seen in many of those programs is they get sucked up by the hospitals and work elsewhere, and they don't come to work in long-term care. So we need to have specific programs that make us a priority. I mean, I think the one biggest lesson learned from this, and you heard from everyone, is we weren't a priority. So if we're going to make staffing a priority, we have to make loan forgiveness, tax credits, incentives to schools a priority to get into long-term care. Otherwise, they'll work in the other sectors. Thank you.
And let me just add, I stand with, I think, all our colleagues in a bipartisan way that we need to weed out the bad actors in this space. And, the star rating systems had, I think, mixed success. But I also know that from just a business perspective, the reimbursement rates are so low and the margins are so thin that those nursing homes that are trying to do the right thing, and I'm particularly concerned now when we've seen nursing home populations, perhaps appropriately after the COVID, and people's concerns fall 20, 25, 30%. I'm not sure what the business model is going to look like, particularly in rural communities where we can keep these facilities open with a level of quality where folks like Ms. Ramos can, there's adequate staffing. Dr. Konecka, could you, I know you've done a lot of research on this, including reimbursement rates. How can we make sure that particularly the good operators are still able to operate, and how are we going to grapple with this issue of, in particularly rural communities, 20, 25% decrease in patient population? What's the model that's going to make this work?
That's an excellent question, but it's a really hard one. This is the hard challenge to answer, right? Because it's almost definitely going to take resources. I think we generally underfund long-term care in this country. I agree with you that Medicaid rates in many states are very low, probably too low to take care of the level of need in a nursing home population. I think moving forward, we have to think about fundamental changes to the system. I think that, there's an aging capital stock of nursing homes. There's financial fallout from the pandemic, and there are chronic problems such as understaffing. So I think we need to take a hard look at the underlying payment mechanism and at the funding we inject into the system, and perhaps consider some bold changes.
Thank you, Mr. Chairman. I know Elizabeth's up, I think, next.
Well, unfortunately,
Senator
Senator Thune came back, so it's going to be Senator Thune next. Elizabeth, we're getting there.
Sorry,
Senator
Elizabeth.
Thune.
Famous
Thank
last
you,
words there.
Yeah. Thank you, Mr. Chairman. And let me just say that the subject of today's hearing is one that I think we all wish we weren't having to discuss, the stories in our states.
Senator Thune, have you been muted?
On. Hello?
Hello, we can hear you now.
Can you hear me now?
Yes.
You got me? Okay. All right. Well, I'll skip the preamble there.
Uh-oh. John, I think we're having trouble with your signal. We'll give it about another 5 or 10 seconds, and then Elizabeth, I think I'm going to have to. Uh-oh, here he comes. Can you speak, John? Tell us if you can hear us. All right, Elizabeth, Why don't you go?
All right. Thank you, Mr. Chairman. I'm sorry, Senator Thin, but I'm sure we'll get this straightened out. You know, when the coronavirus hit, nursing homes were ground zero. To date, at least 130,000 nursing home residents and 1,600 staff members have died of COVID-19. Responding to coronavirus was challenging for every healthcare provider. Genesis Healthcare, a nursing home chain with over 350 facilities across the country, was one provider that struggled. Ms. Ramos, you work at Greenville Nursing Center, a Rhode Island nursing home owned by Genesis. From your testimony, it sounds like working at the facility last year was harrowing. So let me just ask, did you have the resources and the staff you needed to properly care for COVID-19 patients?
Thank you for your question. No, we didn't have enough resource or staff that we needed. But those, like I said before, aren't new issues. Sometimes we have two residents with serious need at the same time, but we have to choose who deserves our care, and every one of them deserve our care 100%. But it's sad that we've been put in that situation all the time.
Well, and you're right, it is sad to be put in that situation. But basically, what you're saying is that you didn't have the supplies, you didn't have the staff you needed when the coronavirus hit. And I know that a lot of nursing homes around the country were in the same boat, which is why Congress passed COVID-19 relief packages like the CARES Act earlier to get providers the resources they need. Now, in January, I wrote to Genesis, which owns the nursing home where you work, and I received information that shows that they accepted $665 million in state and federal grants and loans last year. And guess what Genesis did? It gave its then CEO a $5.2 million retention bonus just a few months before he left the company, which was and is in dire financial condition. In total, the CEO, George Hager, received $8 million in compensation since January of 2020. Ms. Ramos, you told us about how one of your coworkers died while trying to care for COVID-19 patients while working at a facility with a $14 an hour starting wage. So let me just ask you your view on this. Should a top corporate executive have received a multi-million-dollar bonus while you were struggling to keep patients alive and keep yourself alive? Or let me ask it another way. What could have been done to improve patient care with that $5.2 million retention bonus that the CEO received?
No, I don't think they should make millions of dollars in bonuses. Because it's Medicare money, that money should be going to patient care. So with that $5 million that he received we could have put a higher wage so we could attract more staff to the field.
Right,
And,
more staff, more PPE. And that's exactly what Genesis should have done. It should have invested in workers like you. So let me ask you, Dr. Gifford, you're here on behalf of the American Healthcare Association, which represents nursing homes. Do you think it's right that nursing home CEOs received multi-million-dollar bonuses while workers like Ms. Ramos fought for more PPE, more tests, and more resources? Dr. Gifford?
Senator, as a medical director, having worked in nursing homes in Rhode Island, I did not have the pleasure of working with Ms. Ramos there. I saw firsthand, as you've pointed out, and Ms. Ramos says, how hard the CNAs work relative to everyone else. And they are really the lifeblood of an organization. I think early on in this pandemic, there was not PPE worldwide anywhere. And we were hearing from every type of facility out there about the need for getting PPE. and getting staffing, and we were calling it. And what was available was not prioritized for nursing homes. It was going to hospitals and elsewhere. And I think the idea of how we prioritize and use that, the PRF funds that came to us were life-saving. Many of the nursing homes out there are small family-run nursing homes, second, third generation. And this was
So
really,
I'm sorry to interrupt, but let me just, that was not my question. My question was whether or not nursing home executives should be paid multi-million-dollar retention bonuses, or whether or not those millions of dollars should be invested in the resources that are needed to keep staff and residents safe and healthy.
You know, I think it's a good question to think through how compensation is done at all levels, and how are we going to be able to compete for retaining and recruiting staff at all levels throughout there in the healthcare system. And that's something that we'll need to look at. And I think we are fully supportive of transparency regarding how these funds were used going forward.
Well, I appreciate that you're going to look at it, but I just want to be clear on this. We can't allow corporate greed to determine whether or not workers and seniors in this country live or die. And that's why I wrote to Genesis requesting information about their financial decisions. And today I'm going to release their response, which comes in the wake of reports that Genesis will soon be under private equity ownership. I'll be opening an investigation into for-profit nursing homes, including those run by private equity firms. And the next time there's a pandemic, seniors shouldn't be stuck in subpar institutions run by greedy CEOs and vulture firms in order to make a quick buck. Congress needs to act now before tragedy strikes again. Thank you. Thank you, Mr. Chairman.
Thank you. And Mr. Chairman, I see you're back. Senator Thune, I believe, is next.
Okay, all right, thanks.
I believe that's right, Senator Thune.
Thank you, Mr. Chairman. And can you hear me this time?
Yes.
We can.
Okay, good. All right, we're back. Well, I appreciate the subject of today's hearing. Obviously, a huge issue during the pandemic. A lot of nursing home residents isolated, unable to see their families, and quality of care and staffing issues we've looked at, this committee has before the pandemic, and now more than ever, we need to address these issues to ensure that everyone's loved ones deserve the care that they receive. Dr. Gifford, I understand at this time facilities are not required to report to CMS on staff and resident vaccination. Is there no CMS mandate or standard? How are your member facilities keeping track of vaccination records? And I'm thinking about this in the context of future follow-up care once we know more about the longevity of COVID vaccines or the need for booster over time. And so if you could address that. And then, Mr. Dickin, is there anything GAO is recommending on reporting of vaccinations in nursing facilities?
Senator Thurman, you're correct. There's no requirement. All the facilities are tracking vaccination rates amongst their staff and residents internally. There is a portal at the Center for Disease Control called NHSN, where you can report staff and resident vaccination rates. And we have been strongly urging our members to report that. We've been urging CMS and other entities to help sort of move that along. And we are fully open to transparency and having those information revealed out there, just for both quality improvement purposes as well as for family and residents. We've also set a goal of getting 75% of residents vaccinated, and we need that information to see how we achieve that goal. So we're very supportive of that. Thank you.
Okay. Mr. Dickin, anything GAO is recommending on reporting?
Yeah, no, thank you, Senator Thune. And certainly GAO is continuing to track vaccine distribution, as well as efforts to assure that residents and staff and homes are offered vaccines, and to what extent that information is available and transparent. I would note that there are other models in the nursing home setting, that there is reporting now of vaccination for flu or pneumococcal. And so certainly as continue to track the experience in nursing homes with the current environment of COVID-19, GAO is continuing to track that, and the efforts to make sure that there's data available and that can be made available, including at facility levels.
Okay, thank you. Dr. Gifford, as we work to solve quality of care challenges, we also need to be mindful that access remains a priority as our population continues to age. You testified the nursing home industry projects up to 1,600 closures in the aftermath of the pandemic. I expect census declines and COVID-related costs contribute to this. Could you shed further light on the causes of these closures, and if you can, project where in the nation we might be at risk for closure? And of course, I'm thinking particularly where I come of rural areas.
So I think you're going to see the challenge is that the census in the facilities has dropped precipitously from a little over 80% to under 70%. It's been about 15% drop. That's not sustainable. And so I think particularly in rural areas, there are smaller facilities, they're more at risk. I think in states with, as Dr. Cnas has testified, with poor Medicaid rates, particularly some of the inner city facilities where they have a large proportion of Medicaid are also at higher risk because they don't have the same resiliency to sort of sort through this. I think if we're going to make nursing homes a priority to avoid this and increase the staffing and make the PPE available that we need, it's going to have to come through, as Dr. Cnas has said, sort of a serious look at what are the investments we're going to make and how we're going to make us a priority going forward. Otherwise, I think in rural areas, like in your state, you will see closures. It's just not sustainable.
On the staffing issue, everybody on the panel has mentioned those challenges. I've heard that from facilities in South Dakota for years. Recognizing that federal dollars are not unlimited, what solutions should policymakers focus on that will have the most immediate and positive impact when it comes to workforce staffing? Anybody? And I know my time's expiring, so.
Hey, I think we need to get creative in terms of how we look at staffing, right? I'll take the lead from both California and Florida, who have programs by which people graduated from social work, public health, nursing, and one other program are required to participate in programs where they're going into these facilities. And so again, we should give them that infection control and universal health precaution education and start looking at models of intergenerational aspects. And these are just very, simple logistically that we can do, especially as it pertains to our rural communities, because we're going to start to see, as he said, a lot of issues out in those rural communities where we've seen bed size compared to census drop drastically.
Thank you. Thank you, Mr.
Thank you, Senator Thune. Senator Hassan.
Well, thank you so much, Chairman Wyden and Ranking Member Crapo, for the hearing. And I really appreciate all of the witnesses being here today. And I know it's been a long hearing, so thank you so much all for your testimony and your work. Dr. Gifford, I want to start with a question for you. The COVID-19 pandemic has killed more than 174,000 long-term care residents over the past year. More than 70% of all the COVID-19 deaths in my home state of New Hampshire have occurred in long-term care settings. This pandemic exposed clear failures within these facilities and in the oversight of these facilities. The failure to protect this vulnerable population during the pandemic is a national tragedy. There are many reasons that this happened, and you've all discussed a number of them this morning, including the previous administration's failure to quickly and adequately respond, leaving nursing home workers and residents more vulnerable. But nursing homes themselves also need to take a hard look at their own role and take responsibility for their failures. So, Dr. Gifford, do you agree that nursing homes bear some of the blame for the tragic loss of life we have seen over the past year? And assuming that you do, what is the most important thing that went wrong, and what's happening now to correct it during this crisis and into the future?
I think as you've heard from all of us, this vaccine exacerbated some underlying challenges that existed in the facilities, particularly around the staffing issues. But it also, I think, exposed the fact that we lack a priority. We've seen in previous hurricanes and other disasters that the resources go to hospitals and other areas, and nursing homes are not a priority. The other thing was that there just was a failure to learn over time what was the right things to do so we get rapid lesson learned out there. So even as Dr. Cnas said, doing all the right things at the time would not have worked because they were wrong for this virus. I think how we learn from each other was needing to do that. We still don't know what the right frequency of testing is. We don't know whether opening up for family members to come in is going to be the right thing to do and how to do it. Those are critical things that we need to
But Doctor,
know
I'm going
going
to
forward.
interrupt you just because my time is limited. What
Sure.
have you learned that you can change? What could you do differently? Is it staffing that you need to really focus on?
Well, I think we've taken a hard look at that, and I think we agree that we need to have 24-hour RN staffing. Knowing RNs in a facility are really key to infection control. I talked about before about the infection preventionists that are necessary, and we think you need to stockpile PPE for a 30-day supply. We support that.
Okay, so thank you. I want to move to another issue because I'm sure that you saw the recent New York Times reporting on the failures of the federal rating system for long-term care facilities and its reliance on self-reported data. There appears to be a widespread practice of inflating the number of reported staff responsible for patient care by including administrators, some who may not even physically work in the facility. Staff shortages, as all the testimony is established today, have been a major issue during this pandemic. And not surprisingly, research suggests that better staffed facilities lost fewer patients to COVID-19. So Dr. Gifford, given the disturbing record of some homes manipulating data and the importance of adequate staffing, does the federal government need to increase inspections and end the reliance on self-reporting?
So, Senator, I think a couple things on the five-star reporting system. There is this perception of self-reporting. I mean, it's composed of data from the surveyors, so that's not self-reported. The staffing data is from payroll data, which is auditable. And certainly we encourage people to follow the rules on that issues. CMS has identified that there are many directors of nursing who split at their time, or nursing supervisors who will spend some time administratively and some time providing patient care. Some of that administrative time is calling families. So that is why they're counted in that program that's there. So I want to make sure I understand what the process is there.
I thank you for that. I'm going to move on to a different issue, but as
Sure.
someone who has worked in a nursing home, I understand distinctly the difference between being on the phone to families and being at the bedside. I want to turn quickly to Ms. Ramos before my time runs out, because even with vaccine supply increasing, reports suggest that about half of long-term care facility workers remain hesitant to take the vaccine. And I'm wondering, Ms. Ramos, how do you see access to paid sick leave impacting the willingness of frontline workers to take the vaccine?
Thank you for your question. I think that has a lot to do with workers, not only in the healthcare, but in general. A lot of people are hesitant to take a vaccine because they know that there's side effect. And if they take a vaccine and they get sick, they're afraid that there will be consequences to pay. Like they will use their sick time to pay them when they're gonna need a sick time when their family are sick. Or they will use their vacation time when they want their vacation to spend time with their kid, they won't have it because they use that. So, or like for us healthcare workers, we work every other weekend. So if we take a vaccine on a Friday and it's our weekend on, we get sick, we have to call out. We have to make it up the following weekend when we already have plans to spend with our family. So I think it should be a system where you don't tell the the companies to offer, but it will be a law, like a mandate. So it'll be better that way than just like tell them they should offer this and should offer that, because they won't follow up.
Thank you very much. And thank you, Mr. Chair, for allowing me to go over time.
Thank you, Senator Hassan. And we're moving towards wrapping up. And there are a couple of areas I want to get into because I think we may have missed them. Question for you, Ms. Botcher and Dr. It's important. What do you two think?
Senator, I think it's incredibly important. And in fact, I spoke to one of our members yesterday, Mark Ferguson in Lake Charles, Louisiana, and I posed the same question to him. How important is it that you know about the vaccination rate at your brother's facility? And he said it was extremely important. And particularly, although his brother has been vaccinated, it's important because as we look into the future and if they need a booster shot or infection rates start climbing, he wants to know that information about his brother's facility.
All right. Dr. Konecka.
I agree. I will just add that, yes, we certainly need that information to be public for consumers. They have a right to know the vaccination rates in a facility they might be considering. It's also essential for researchers and for public health officials to have that data to track vaccination rates, to figure out what's working and what's not working, and whether vaccination is proceeding with equity. So I think there's no excuse that those data aren't made available publicly yet.
Good. And the last question, I think, on my end, and then I want to kind of sum up where we are. Dr. Konecka, do you have any additional recommendations? I had to be off on the floor voting for a bit with respect to what can be done to deal with these yawning racial disparities, these enormous racial disparities. To some extent, they mirror society, as I touched on earlier, but to some extent, they seem to be even more entrenched, and it is going to take more careful efforts to root out. Do you have any final thoughts with respect to racial disparities in nursing homes?
Yeah, it's an incredibly important issue. So as I said, I think we know that racial and ethnic disparities have been prominent in the pandemic, not only generally, but also in nursing homes. And at the same time, long before the pandemic, people of color tend to be in lower quality nursing homes. And those nursing homes have a higher Medicaid census. Those nursing homes tend to have lower staffing ratios. I think in the short run, and this goes back to your data question, in the short run, what we need is data on vaccinations to make sure that we are reaching those communities, the communities of color, but also the nursing homes within them, and that we are getting people vaccinated in those areas. We need to make sure that strike teams are also reaching those larger facilities in lower income neighborhoods. The long run problem is harder, again, because as you said, it sort of reflects residential segregation and the problems that go along with wider disparities in the healthcare system. But in the short run, we can certainly target communities of color to try to reduce those disparities.
All right. All of you have been a terrific panel, and as you could see, my colleagues kept coming back to important points. Dr. Konecka, as you know, I think almost 3 hours ago, I asked you about private equity and the fact that they seem to be bringing make money first and patients somewhere later will be discussed kind of philosophy, and colleagues kept talking about that all through the hearing. So we thank you for that, and I could literally go person by person and mention your contributions. But I think I want to close.
Chairman, I'm back now. Senator Whitehouse.
Okay. Okay. Would you like to ask anything else, or do you want to make?
If I could drop in one question to Ms. Ramos.
Good. And then I'll close it out. Go ahead.
Ms. Ramos, when I introduced you, I described the amazing tragedy that you lived through with all of the fatalities at the Greenville Nursing Center, including a colleague, yourself getting the illness, the four of you having to try to manage, what was it, 24 COVID patients. Could you just put as much of a personal experience before us of what this all felt like for you and your colleagues working in the Greenville Nursing Center, and what you've heard from other colleagues who've been doing the same work in our nursing homes?
Thank you for your question. So before COVID, we were going through those issues, and we've been fighting at the state level to pass the safe staffing, as you know, because it's been years and years that we've been working understaffed. And the quality care for residents is getting worse and worse, and the pandemic made it even worse. So on those times, I remember when our first unit got COVID, we weren't allowed to visit our patients that we normally pick up a shift on those units that we've been know forever. Um,
You know them well. I
our
mean, they're people in your life, right? The patients.
Yes, they like a family to us. So we kept texting our coworkers in that unit and encouraging them, and they kept telling us what was going on that unit. If it was a normal day, we know that somebody's dying, we could stay over after our shift and spend time with those residents. But because they were COVID unit, we couldn't go there, and we felt guilty when we heard such and such passed away and we couldn't be there, their family couldn't be there for them. It was heartbreaking. And then when it came to my unit, which is a dementia unit, it was horrible. Like I said before in my open statement, we were working short. There was 26 residents that was very ill, and the other CNA and I and a nurse and a housekeeper. um the nurse was overwhelmed she has a lot to do and she couldn't help us, and we couldn't help her, so we had to do the best we could. I remember my resident telling me she was scared, and I kept telling her it's okay, and then she was like, no, can you stay with me? And I couldn't stay with her to hold her hand, and I held her hand for a few seconds, and then I told her I have to go because somebody else needs me. And she looked at me with a sad face and she didn't want me to leave. And her family couldn't come in to hold her hand. Um, and then I remember that day, a resident passed away. Um, and then the funeral homes couldn't come in to put to get the residents. They normally in a regular day before the pandemic, they come in and pick up the residents, and we walked away once they put the resident in the bag, and we walked out the resident. So our job was a resident passes away, and we have to. It was the hardest part. We had to put the resident in a bag, in a body bag, and those are the residents. They're like a family and we love them. So imagine if it's your own family that passed away at home and you have to put them in a body bag, and then we have to bring them outside. So it was horrifying. um we work short all the time, and I am glad that we have a union that has our back. We made complaints, and the union did what they had to do, and then finally we got agency staff that came in to help us. But the the thing is, management weren't there to help us, and like when we need help, we ask for help from management. If I'm a CNA and a nurse and another CNA and we're feeding a resident, and because that resident can feed herself or his, like, so then we call for help to come feed. They don't come to the floor. Another resident asks me, I need to go to the bathroom. So I have to make a choice right there and then. I have to leave that resident with the tray in front of them that resident can feed themselves and take the other resident to the bathroom. Because we're short staffed, we don't have another staff that would take over. And those are the choices that we have to make day to day. Before the pandemic and with the pandemic, things got worse. And it is a sad situation, but I don't think it should just be a state level that we're fighting for. Our union is fighting across the country to change the staff in a nursing home. I think you guys have the power and that you can change it and have oversights in these nursing homes and make it better for the quality care for our residents and for our staffs, because our staff are not leaving the nursing homes because they don't want to work in the nursing homes. That's not the reason why they're leaving the nursing homes. They're leaving the nursing home because the workload is a lot for nurses and the CNAs, and they go work at the hospital when they will get less patients, and they pay them more than a nursing home. They don't want to leave their residents, but they have to look at it. It's their health too that's at risk, and they don't want to go home exhausted after a long day at work, you know? So
Well,
we
thank
have
you so
to-
much, Ms. Ramos. People call you and your colleague heroes for a reason. You are heroes of the heart, and I thank you for being here.
Ms. Ramos, you've got another senator who I'm sure is very interested in your views as well, and we want to hear from her, Catherine Cortez Masto.
Thank you. You to the chairman and ranking member. This has been an incredible conversation. Ms. Ramos, I'm going to follow up because I truly agree with Senator Whitehouse. So many heroes on the front line right now, including so many at SEIU and the work that you are doing. My challenge has been, and I'm hoping you can help with this, and I think this was the conversation you were having, was how do we attract more staff at the long-term care facilities? You talked a little benefits and other things. What should we be doing? How do we attract them to make sure that we're not only getting them into the facilities because they're understaffed, but taking care of them as well?
Thank you for your question. The way that we attract them is to put the starting rate higher than what it is right now, because nursing homes starting rate is very low for CNAs, and they can go to hospitals and make more, or they can work for agencies that are making double what we make. So those are the challenges, and also the staffing. They need to change the staffing in a nursing home, because if someone starts working in a nursing home and they end up having 12, 13 patients that are total care that can do anything for themselves, within 3 months they leave, and they get the experience that they need. They leave the nursing home and they go work somewhere else because they're like, I can't do this job because it's a lot and they don't pay enough. So those are the main challenge that we face in the nursing homes. And I am grateful that I have a union that fights for like better wages and better staff in a nursing home. But we've been fighting for it state by state. We want this fight to go across the country.
Thank you. Thank you so much, and for your advocacy. It is so important. Let me jump to I believe it's Dr. Konetska. And I know there's been talk about private equity now being involved with long-term care, but can you opine on what sort of guardrails the Congress should consider to ensure that additional resources that flow to long-term care facilities are invested in patient care and staff?
Yeah, it's an important question. And I think the first step is transparency. Right now, we just don't know where the money is flowing. So, we need to make reporting of those arrangements mandatory, and assess where we are and whether current reimbursements are enough or what else we need to inject into the system. And then I think the next step would be to consider some more oversight or regulation of these arrangements. When there's so much public money involved, I think some accountability is warranted. And we should be able to make sure that when we put Medicare and Medicaid money into nursing homes, that at least a certain proportion of it goes to patient care.
Thank you. Again, this conversation today has been so helpful, I think, to all of us, and so appreciate having the hearing today. Mr. Chairman, yield back to you.
I thank my colleague, and I know of her advocacy for seniors. Here's my take on where things are in. This has really been the area I've focused on in my time in public service. I was director of the Gray Panthers, ran the legal aid office for elderly, and I have long known that from sea to shining sea, there are persons who care deeply about the well-being of those patients in nursing homes. And Ms. Ramos, I can tell you, because I visited with a couple of my colleagues when we were voting, you have left our members with a very clear call to action. And you've spelled it out. Here are the problems, And the buck is not at the state level or the local level or anywhere else. It's in the United States Congress. And the Senate Finance Committee has jurisdiction over this area. So I so appreciate what you've done. I appreciate all of you. And I think if I were to sum it up, that despite all of the caring and good people who work in a number of nursing homes in America, we have still seen in the last year what I describe as a collision of mismanagement at every level. And Ms. Ramos started it off 3 hours ago when she talked about understaffing and infection. And then she talked about the problems with PPE, not even being able to get basic protective equipment. And then she described, hey, by the way, we're also kind of in the dark. We've had difficulty getting information. So I've had a number of opportunities over the years to hear about what needs to be done in terms of long-term care. And I think this has been a stellar panel. You've spelled it out. Ms. Ramos has made it real clear. She's going to hold the Congress of the United States accountable. And that's exactly what we need. So I want you to know that I guess I'm calling an end to the hearing for today. But let me tell you something. This hearing and the issues that we're going to be focused on because of what you have said today and your call to action and accountability, this is not something to be swept away. This is to be continued. I thank you all. Terrific hearing and look forward to staying in touch. Oh, I have one other matter. I'd like to thank Ranking Member Crapo and all committee members for their participation. We thank our witnesses, of course, and for information of all members, question for the record should be submitted by 5 p.m. on Wednesday, March 24th. And with that, the hearing is adjourned.